All right, welcome back, people. Today, June 8th, it is 10:02 in the morning. Probably could have slept a little bit better, but coffee's starting to kick in. Bon Jovi's helping a little bit. We are actually kind of staggered a little bit. We are still working on neuro. We're going to be jumping into some of the cord cross sections again, the cord in general. Like, where does the cord terminate? Why do we care? What's the gray matter? What's the white matter? Tracks, obviously, finish up with that. And again, I'm going to talk a little bit about maybe peripheral nerves and nerve root discrimination, like how we discriminate one from the other. Just real briefly, nothing deep. I think I mentioned it a little bit before, but it's always good to kind of reinforce that. So we'll look at a picture of maybe dermatomes. Obviously, when we end up getting to a test, we're not going to have multiple choice questions about dermatomes. It's just kind of hard to write, But the other reason I don't tend to ask questions specifically about dermatome locations is it'll change depending on the source. So if you're learning it one way for your physical exam and I teach you a different way, then that's going to mess you up a little bit. Some are always consistent, like C7 is always kind of in the middle of the palm and stuff like that. But L1 through L4 changes, and C8, T1, and C4 through C6 sometimes changes their exact location, but we're just going to get a general overview. So again, I've already opened up my neuro section, and we're also going to start working on neurosensory today, but we are staggered a little bit. So today, obviously, by the way the meeting's set up, we were going to just do neurosensory, but we still got to finish this. So we're going to work on that first, then head into neurosensory. So whatever we don't finish with that today, we'll pick up with that next Tuesday. Then we'll start working on autonomics and endocrine. And then whatever we don't finish with that, we will push over into next Thursday. So again, overall, though, we're still doing fine. Our first week, we had a little bit of fluids and electrolytes. We started working on neuro. We're still working on neuro now. We will get neurosensory done either Thursday or Tuesday, and we'll finish autonomics and endocrine by the end of next week. And that still keeps us on pace. So our first lecture exam, that's already kind of typed up, written. It's ready for you to take it. That's going to tentatively be due on June 18th. So if you can get it done by the end of next weekend, that would be ideal. That'll keep you on schedule. But if something comes up and you don't get to it, obviously, just let me know. And if you can't open it, just let me know, because I can extend the date. But they do want me to put a date on it. And I'm, you know me, rule follower all the way. So, but the first exam, 50 questions, multiple choice, and it's just going to come from, a little bit of everything. So maybe 5-10 questions from fluids and electrolytes, 10-12 questions from neuro, probably a little bit more from neuro just because it's so long. But same format as what I normally do. And again, if you didn't have me before, ABCD. So if I end up having something different on the test, I'll let you know ahead of time. So if we end up having like a written portion where you got to type in an answer, I'll tell you ahead of time. So usually I don't like to surprise people with stuff like that. But anywho, I've already got my neuro section open, so I'm just going to switch screens with you. But again, we're working on this one. We'll do this one after our first break today. So we'll switch over to that after our first break. But we're heading back into this one. And I think we left off right about here. We just got done with the reticular formation. Moving into the spinal cord. And again, we're going to mention tracks again, which should be a good review for most people. If you didn't do tracks at all, just let me know, because I will try to go through those things fairly quickly. So we're talking about things like dorsal columns, or maybe you might have called it posterior columns in your class, lateral spinothalamic tract, corticospinal tract. We don't do all the tracks in my class. Not all of them are super clinically relevant. Some are going to be very rare that you would ever see in the real world. So we just kind of skip over those. But if you've never covered tracks at all, or if you have no idea what I'm talking about, just type in chat or let me know, and I will be more specific. the way I describe those things? If not, then we'll just kind of say, here's this track, here's what it does, here's what we would expect to see if it's not working. But before we get into the tracks, general information about the spinal cord and the peripheral nerves that are coming off of that. The cord itself is still part of CNS, of course, but it's kind of our in-between between the brain and the body, if you know what I mean. Like when I think about CNS, most of the time, the ultimate destination is the brain itself. And what we're trying to do is we're trying to interpret information that's coming from our environment, both internal and external. And the environment is what our body kind of lives within and amongst. So the big idea about neuro is we're trying to take information from the body to the brain and the brain back out to the body. And the cord is usually how we do that, right? It's a conduit, sometimes we call it. And so it's connecting the brain to the body and vice versa, the body to the brain. The reason we don't always say it that way is the cord itself does provide some responses on its own. So, sometimes the cord itself can control things called reflexes, right? Here's that term I was just using a minute ago, a conduit, kind of the in between the brain and the body. But the cord itself can perform certain things like reflexes. So when we were in Anatomy 1, I might have showed you examples of, like, say, a withdrawal reflex, where essentially, like if I were to touch something sharp or touch something hot, I would have the ability to pull away from it. Like if I touch something sharp, let's just pretend this hurts, and I press that and I pull away real fast. That's called a withdrawal reflex. And that's something that the cord can manage on its own. It doesn't need the brain to do that. But a lot of times, certain basic things, just like touch and pressure and even vibration sense, what they're going to do is they're going to get picked up by a peripheral nerve somewhere out here. And at the end of the peripheral nerve, we're going to have these specialized nerve endings called receptors. Your skin ends up being a very large part of the nervous system, in that it's going to provide most of our sensory input that's somatic in nature. Right. Again, the somatic stuff is the stuff that we can consciously feel. So stuff like touch, and touch can be, different. And we'll talk about that more with the neurosensory, but you have like light touch and crude touch. I can feel specifically what's touching me. I can tell that something's touching me, period. Right. So there's different types of touch. And pressure, how deep a pressure is it, which could maybe help me determine weight, or how much compression is pushing on the body, vibration sense, and even parts of proprioception, like the joint angle and the joint position awareness. Skin actually helps us with that too, because you can see the skin has been compressed right there, where the joint angle has gotten smaller, and the skin's actually being stretched out back here, where the joint angle is kind of getting more obtuse. So skin even helps with that as well. It even actually helps us pick up a little bit of proprioceptive information along with the muscle stretch and the tendon tension. So skin's a big part of the nervous system. And in our skin, we have lots of different types of receptors, which again, we'll mention when we get into neurosensory. But eventually that information will get picked up somewhere out here, say in the body. And that information will then head to the cord, and it'll head to the cord along the appropriate, say, peripheral nerve, and it'll connect with the appropriate portion of the cord. So if I'm picking it up from, say, the hand or the upper extremity, then it's going to get picked up by this part of the cord. If I'm picking up by the foot or the lower extremity, it's going to get picked up by this part of the cord. And most of the time, what ends up happening is the cord will then transmit that information to the brain along a tract. Right. So I'm doing a very broad discussion right now, nothing, super succinct or specific, but a lot of times, whatever we're picking up from the body through receptors, they're going to travel along some type of peripheral nerve to the cord. And again, the peripheral nerve will attach to the cord in a very specific location, depending on where that information was coming from. And from the cord, we can then carry it to the brain. The brain can then make that decision about what we're going to do about it. Maybe send information back down the cord and then back out again. So that's a lot of times what they mean when they call the cord a conduit between the brain and the body. It's what's connecting this to that ultimately. You might come in here, go up there, back out here, or you might come in from the leg to the lower portion of the cord up to the brain, brain will determine, go back out to the body. But there are certain things that the cord itself can control, and some of those things are basic reflexes. So a deep tendon reflex actually is one of the things that the cord can do by itself, something called a withdrawal reflex, and there's actually something called a crossed extensor reflex that kind of helps with movement, walking, balance, all that kind of good stuff. It's essentially why when we walk, our arms kind of swing at the same time, and when one arm swings forward, the other one goes backwards. But again, the cord's not really going to be doing a ton of stuff for us, but if it does, sometimes we refer to those things as reflexes. But anywho, cord, when you look at what's coming off the cord to connect the body to the CNS, which of course the cord is part of, we do have what's called 31 pairs of peripheral spinal nerves. So when you get into the peripheral nervous system, again, it can be anything that's coming off brain or cord. But if it's specifically coming off the cord, we just simply call them spinal nerves, right? So you have 12 pairs of what's called cranial nerves that come off the brain itself. Those are the ones that you memorize, right, in a particular order, like, oh, once one takes their anatomy finals, very good vacations are heavenly. And some say money matters, you know, but big boobs matter. But my brother says big boobs matter most. That's what we learned all that stuff for. That was learning the 12 pairs of cranial nerves by name. We eventually learned them by function. So that'll come back up again in neurosensory. But when you get into the part that's coming off the cord, those are going to be made up of 31 pairs of what's called spinal nerves, right? So again, all that's part of the peripheral nervous system. CNS is the brain and the cord itself. And then the peripheral nervous system is everything coming off the brain or coming off the cord. So you have 12 pairs of cranial nerves and you have 31 pairs of spinal nerves. Those are all examples of peripheral nerves. And specifically with the spinal nerves, these are all what's called mixed in nature, right? Not only are they picking up sensory information, they're also carrying motor information, and all 31 pairs will do that, right? That's different from cranial nerves, right? The mnemonic I just gave you a second ago, obviously the once one takes their anatomy finals, very good vacations are heavenly. That was the mnemonic for memorizing the names of the cranial nerves, right? Olfactory, optic, oculomotor, trochlear, trigeminal, abducens, spatial, vestibulocochlear, glossopharyngeal, vagus, accessory, hypoglossal. But you also had to memorize their functions too. And some of the functions were strictly sensory in nature, like smell or vision, right? And some of the functions were strictly motor in nature, like say oculomotor, which is for eye movement, right? And it moves 4 of the 6 extrinsic eye muscles. And so we might call the ones that are just picking up sensations sensory in nature. We might call the ones that are just doing, sorry, that's my dog, that's just doing movement, motor in nature. But then some of the cranial nerves were what was called both or mixed. So S stood for sensory when we were doing this other mnemonic. M stood for motor. And then we had a B when we learned our mnemonic, which stood for both. But some books will call it mixed, which obviously that would be confusing with motor. So that's why we call it both. So if you learned it as mixed, it's the same thing. But some say money matters, but my brother says big boobs matters most. Would tell you whether these cranial nerves were strictly sensory, strictly motor. So like oculomotor moves the eye, so does trochlear. It's just eye movement. It's not picking up vision. But then when you got to trigeminal, it was both. Remember, trigeminal picked up sensation from the face. So when you look at trigeminal is called trigeminal because it's got these 3 kind of equal extensions. So trigeminal, right? Gemini means twin, tri, 3, so triplets, right? You got these 3 branches that come out in front of the ear. So this is called the ophthalmic branch. That's called the maxillary branch. That's called the mandibular branch, or 5-1, 5-2, 5-3. And all parts of trigeminal nerve could pick up touch. So I could touch the patient here and I say, can you feel this? And they'll say, yes. I'm like, how about here? Can you feel that? How about here? Can you feel that? Yes. Any pain associated with that? No. So maybe we can rule out trigeminal neuralgia, you know, if they had some type of facial pain or headache or something like that. But then I could also ask the patient to bite down like they're chewing, and I could put my hands right here, my fingers right there, and I'll say, go ahead and bite down like you're chewing, or I could just look at them if I wanted to, and I'm going to see if that masseter muscle contracts, right? Because if I have my hands kind of on their jaw and they bite down like they're chewing, I can feel that masseter muscle contract, and that's the motor component. So it was both sensory and motor. It picked up sensation from the face, and it also controlled muscles of mastication, right? We can do this again with neurosensory, but it was mixed. It had both sensory and motor. So one distinguishing characteristic about spinal nerves is they're all mixed, all mixed. So if I have some type of deficit because of spinal nerve injury, then I should be missing both components usually. I'm going to usually be missing sensory and motor. So I might have some type of unusual sensation associated with it. Plus, I might lose the ability to control something, right? Or it might be weaker. I might still be able to control it, but it's having difficulty doing that, right? Or you might even see things called twitches and fasciculations. So maybe the muscle that it does control twitches a lot, or it has like little ripples of what look like muscle contractions underneath the skin. So again, there's something different about the motor. There's something different about the sensory. It doesn't necessarily have to be completely lost, but something has changed, right? So again, I know that's really kind of very generalistic, but it's good information, right? Because if you know the 31 pairs of spinal nerves are all mixed in nature, if there's some type of spinal nerve injury, then I would expect the patient to lose both sensory and motor function in some way, shape, form, or fashion. So that's why we mention that information. Okay? But again, most information that's going to the cord eventually is going to go up to the brain, and the brain's going to do most of the decision making, and then it's going to send a signal back down the cord and then back out again. So as we're behaving as a conduit in the cord, that's where terms like tracks come in. So we'll talk about tracks, and then we'll also talk about something called a reflex arc. We can show you how things are wired if the cord's in control, or how things are wired if the brain's ultimately in control. Right? But anywho. A couple of tidbits that's also mentioned on these things. You know, here's the total numbers. Here are the numbers coming from each region. So when we do, and I know this is all very basic information, but it's always good review. When we do numbers and naming of different types of nerves in the body, cranial nerves are very unique. You know, cranial nerves are, I'm just going to write it out rather than put in. But cranial nerves, usually we will indicate them by name, like you could say olfactory, right? Nerve, or by letters and numbers, in which we would put CN, capital C, capital N, and then Roman numeral 1. So cranial nerve 1 is the same thing as saying olfactory nerve. They are synonymous with each other. Same thing, cranial nerve 2, that is synonymous with optic nerve. So you can say one or the other. And of course, we need to learn it both ways, even if you've never learned Roman numerals, because like cursive writing, I'm sure that's disappeared over time. That's how it's going to be presented to you. Like some questions on a test, it's going to say, you know, what would happen if I have a lesion on optic nerve, and then maybe you would have, you know, vision loss or blindness. But, you know, another test will say what happens if I have a lesion on cranial nerve 2. So obviously we have to learn it both ways, but that's why we learn it using that mnemonic, because we're learning it in the appropriate order, going from what's called rostral to caudal. Right. So if I look at the bottom of the brain, like let's pretend this is the bottom of the brain, like your olfactory bulb is the very first cranial nerve. And then your optic nerve, right, is the second one. And then it would just keep going. Right. And so that's how it's coming off the brain. So here's cranial nerve 1, here's cranial nerve 2, you know, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. right? It's going from what's called rostral, most toward the nose, to caudal, most toward the tail. So by the time we get down to cranial nerve 12, we're all the way at, say, the medulla, which is basically the end of the brain, and that's where the cord's about to pick up, right? So that's nice. It's a good numbering system, believe it or not. And so if we end up doing a cranial nerve test on a patient and they have a deficit of a cranial nerve, then maybe we could expect there's a lesion somewhere on that cranial nerve. And if it wasn't there yesterday, but it's there today, then I can maybe assume that that lesion came from a stroke. And now I can figure out which part of the brain has been affected as well, because we know approximately where it's going to come off, right? So that's, again, very nice and useful. So similarly, when you get into spinal nerves we will also name, and I'm just going to go ahead and abbreviate it this time. NN is just an abbreviation for nerves. You have 31 pairs of those total, but you have a certain number that comes from each section. So in the cervical region, where of course no ribs would be attached to the vertebra, right? You have a thoracic region in which ribs are attached to the vertebra. You have a lumbar region in which, again, ribs are absent, right? So vertebra are cervical, thoracic, and lumbar too. But when you get into the spinal nerves, even though most of the numbers are going to stay very similar, the cervical ones are going to be slightly different. So when you get into spinal nerves, we have 8 pairs of cervical spinal nerves, even though in the vertebrae, you only have 7. Okay, so we have to memorize that. But the rest is going to kind of be the same. Thoracic spinal nerves, we have 12 pairs of those. You know, one's coming off the right, one's coming off the left, or each side. So that's why we say pairs, right? We have 12 thoracic vertebra, and lumbar, you have 5 pairs, and you have 5 vertebra. And then when you get into sacral, of course, we have 1 sacrum, but it's a bunch of fused lumbar vertebra. So even though we only have 1 sacrum, you have 5 pairs of spinal nerves that come off there, and then coccygeal, or the coccyx, right? Even though it's kind of like 2 bones, but we have a coccyx, right? So that ends up being your 31 pairs. So 8 plus 12 is 20, 25, 31, right? So you have to memorize that, right? 8 pairs of cervical spinal nerves, 12 pairs of thoracic spinal nerves, 5 pairs of lumbar, 5 pairs of sacral, 1 coccygeal pair. And when we number those things, we'll number them like this. We'll put capital, say C if I'm in the cervical. So let's say I'm in the cervical region, capital C1. That means my first cervical spinal nerve. That's what that means. So that C1 equals first cervical spinal nerve. And now you see why we abbreviate everything, because I don't want to write that out. I can just write that. C2, C3, C4, C5, C6, C7, C8, okay? And that stuff, believe it or not, comes up all the time, you know? Sometimes we will be testing a patient's dermatomes, which is a word I mentioned to you earlier, and dermatomes are based off areas of skin that are innervated by particular nerve roots. So here on this picture, that's what that picture is kind of showing you. It's showing you dermatomes. The picture I learned when I was in school was this one. Came from a book called Netters. Netters is the pretty traditional medical anatomical manual. Everything's kind of drawn in, you know, it's hand drawn. They're pictures, they're not digital images, but it's still kind of like the holy grail of anatomy. So this is the image that comes from Netters. That's what it says right there, is Netters. Okay. So here's your C7 dermatome. So let me show you how that gets used. So for example, you can see the palms of my hands right here, okay? Thumb side is going to be represented by what's called C6 dermatome. And a dermatome is an area of skin represented by a nerve root, by a particular nerve root or spinal nerve, okay? And so my C6 spinal nerve, the nerve root for that, is responsible for this. C7 would be responsible for that. So C6, think maybe thumb side, hand, C7, middle of the hand. Okay, so let's think about ways that spinal nerves could be affected. So how would spinal nerves be affected? Maybe through some type of crush injury, right? I think my wife, she was at Piedmont yesterday, and one of the patients had a four-wheeler roll over top of them. So obviously I'm not going to give any names or anything like that, but the big problem was he came in with very minimal pain. But because of the way they moved him in the hospital, he left with much more. So that's a problem, because some of his thoracic and lumbar vertebra were broken. And when they were moving him from one place to another, I think some of the bones got shifted, and it ended up causing him much more pain and agony than what he showed up with. So he had some probably hairline fractures that ended up being full comminuted fractures after that. So obviously crush injuries to maybe the vertebra themselves, right? So if I have broken vertebra, but way more commonly is going to be things like disc injuries, right? Like if I get some type of disc injury, the disc themselves, which we usually find in between vertebrae. So let's say that this is a vertebral body right here. And let's say that this is the next vertebral body. The nerve would usually exit somewhere along in here, right there, like that. So there's a neural foramen that's usually made. The upper part of the neural foramen is going to be made by the vertebra above, and the lower part of the neural foramen. So this thing right here is called a neural foramen. It just means a hole in a bone, a foramen, right? And it's for a spinal nerve. So this would be a spinal nerve, and this would be the area of the nerve root, okay? And so let's say that this is C7 nerve root. This is the C7 spinal nerve. So there's a disc that would sit right here, you know, in between the vertebra, right? And when you're in the cervical spinal nerves, watch this. Let's say this is C1 vertebra. So these are vertebra. This is C2 vertebra, C3, C4, C5, C6, C7, T1, sorry, I didn't mean to say C8. So C7, C6, C5, C4. So if you ever wonder, why do we have, 8 cervical spinal nerves when we only have 7 cervical vertebra, is most spinal nerves are named from the vertebra above. So normally, if you had a spinal nerve that came out below C1, it would be called the C1 spinal nerve. But in the cervical region, it changes, because we end up having a spinal nerve that comes out above C1, which ends up being our C1 spinal nerve, and another one that comes out below C1. So that ends up being called C2. So now you have C3, C4, C5, C6, C7, and look, we're still in the cervical region, C8, right? So C8 spinal nerve comes out above T1, right, below C7. So that's where the numbers get off. And then once you get to T1, right, like let's say this is T1, T2, right, vertebra, then now that's T1, T2, and then it goes back to being normal again. So if I'm trying to test some of the skin right here, like if I touch this area of the thumb, I'm actually testing the C6, what's called dermatome. That's going to be picked up and carried by this spinal nerve right here, right? It's going to be, this spinal nerve right here. So it's going to be picked up and carried by that spinal nerve. But if I end up having some type of disc herniation, like if I have a disc herniation, then that can compress that root. So you would usually see some type of change in their dermatomes, right? So if somebody has nerve root compression, if you end up having nerve root compression due to disc herniation, then they're going to lose sensation in that particular dermatome. So it's a nice test, because if you know somebody's had some type of spinal injury, or if you know that they've had complaints of neck or thoracic or back pain, then that could be an easy test to do to figure out where the problem might be. Because, I mean, you can obviously get regional, like he's got neck pain, but what part of the neck? You know, is it the upper part of the neck, the mid part of the neck, the lower part of the neck? You could even get it down to a single level, right? So if a person has, for example, numbness of C7, but C6 and C8 feel normal, then I know the exact place where that disc herniation is at. That's the usefulness of dermatomes. So dermatomes can really, really localize a lesion if the lesion happens to be near a nerve root, right? And the most common reason we would have nerve root lesions is because of disc herniations. But again, that's going to be the most common type of back injury as well. So that's good. It's good. So we can actually figure some of that stuff out. But again, some of the basic stuff is very applicable. It's very usable, right? So let's see. I'm not too concerned whether you know this stuff or not. If this were like a strict anatomy class, you know, there are parts of the cord that look different from other parts of the cord. There are some things on here I do want you to know for this page, but I'm not going to be asking about cervical or lumbosacral enlargements. Numbers are good to know for sure. You know, always know that. But this is just basically saying our cord doesn't look the same all the way down. Some parts of the cord are thicker than others, so we might call those things enlargements. And it's kind of like a duh statement, because if I have more body parts I have to feel or control, then I'm going to need more myelinated axons. So the cord itself has to be bigger. So since in the cervical region, we're controlling all the upper extremities, you know, and in the lumbosacral region, I'm controlling all the lower extremities, then of course, those are going to have bigger portions of the cord because they're responsible for more stuff. So that part we don't really care about when the cord starts to change and look different. This part, though, we do, right? So as you're looking at the cord, right, and as the cord spans its way down, eventually your cord actually terminates, right? Even though we already told you that we have 31 pairs of spinal nerves, and that goes all the way down to the coccyx here, right? The cord itself doesn't go all the way down to the coccyx. The cord actually stops at about the L2, L3 disc space. So right about here, okay? So your cord terminates and forms something called the conus medullaris, which is just a cone-shaped tip in the middle, right? So we could probably see that if we want to. Let's see here. Let's look at the old Google machine, and let's just type in cord laminectomy, cadaver, and let's see if we can find a conus medullaris. So this is actually a nice picture. That's why I clicked on it. But here's the cord itself. Right? You can see the cord heading down. You can actually see some of these little nerve roots heading out toward the side. So that's kind of nice. Here, they're already labeled for you, dorsal rootlets, and then they'll probably have a ventral one labeled somewhere else. But the reason they're able to tell which ones are dorsal versus ventral roots is because the dorsal roots always have that enlargement called ganglia on them. Ventral, it'll be absent. And it usually takes quite a few what's called rootlets to end up making the entire root. You can see that on some pictures. But here, as you get further and further down, you'll see that the cord itself eventually just kind of stops and it forms this little cone-shaped portion in the middle. And then you have this thing called filum terminale that goes all the way down to the coccyx. But that's the end of the cord itself. And so that's called conus medullaris. And then, of course, since we still have spinal nerves that have yet to exit yet, you know, we still have like the L3 spinal nerve, the L4, L5, you know, S1, S2, S3, S4, S5, C1. Those still have to exit. So they come down as a bundle called cauda-equini, right? So these are cauda-equini. Looks like a horse's tail, and there's the conus medullaris. right? So that's important, right? So we want to know where conus medullaris is. We want to know what level it's at, because that will be important. We also want to know what cauda equini is, because there is something called cauda equini syndrome that's a very bad thing to get. So here's a little picture. There's like a lateral MRI right here. And here you can see what some people might call a disc herniation, but this is actually a prolapse disc is what this is. So the difference between, say, like a disc herniation and a disc prolapse is herniated material has not fully extruded all the way. Herniated material is still encased within the disc. And so if you can do some traction maybe on the spine, it'll usually come back in, right? Slowly, it takes time, but it'll heal itself. But when it becomes completely extruded like this, the fluid material that's inside the disc, you can actually see it right here and here. So on this particular MRI, the fluid is light in color and the solid material is dark in color. So that's some of the cauda equini right there, right? So that's part of your cord, right? In cauda equini. Here's the entire disc, but a lot of your disc is annular fibers, but it has a nucleus pulposus in the middle. And the nucleus pulposus is kind of like the squishy part, right? So in this case, that nucleus pulposus has been compressed so hard that it's squirted out, right? And so you got annular fibers out here. The nucleus is basically gone. So this is a full prolapse disc or an extruded disc. And look where it went. It's compressing the cord. And not only is this fluid and this material out there compressing the cord, the fluid inside of the disc is caustic to the cord, so it'll burn it, right? So that's a big problem. So we call that cauda equini syndrome. So when you're, nerve roots that have exited beyond the conus medullaris, they bundle together, they end up forming the cauda equini. When these things get compressed, if you have a really bad low back injury, then that can cause what's called cauda equini syndrome. So, sorry, that was weird. The surveillance system just had like a person's face, like really, really close to it. I think they were seeing if it was a camera or not. But disc prolapse or disc extrusion, if that kicks out into the cauda equini nerves, we could expect the patient's probably going to present with some type of what we call saddle paresthesia, loss of bowel and bladder control. So this ends up becoming a big problem. So they might poop themselves, they might pee themselves, and they can't feel anything wherever you would sit on a saddle. That's what it means when you call it saddle paresthesia. So this whole area gets basically numb or loss of feeling. So in this case, I think this is supposed to say laminectomy or lumbar discectomy. This is where a laminectomy occurred. So here what they've done is they went in and they just cut the back of this vertebra out. So that's why it's missing right there. You don't see, here's like a spinous process right there. Here's a spinous process. Here it's what's happening here. They cut it out. So that relieved all the pressure that was there. So that's one way you could fix it, right? Or if they did a lumbar discectomy, they could actually come in from the front. So you could actually come in from the front, you could suck out any material that was left, but in this case, this was the better fix. Okay. So there you go. There's a use of basic terminology. So what is cauda equini? It's just part of the cord. It just happens to be the part of the cord where you still have nerve roots exiting past conus medullaris, but there's clinical application to that. So if somebody comes in and they present with saddle paresthesia or saddle anesthesia, like numbness and tingling, or complete absence of feeling, right, and loss of bowel and bladder control, you know something's probably compressing that cauda equini, right? So again, it helps you localize lesions, Let's see. Here's another good reason we want to know where the conus medullaris is. So conus medullaris is the tip of the spinal cord, and the spinal cord terminates at about the L2, L3 disc space, right? So if I do want to do some type of CSF test, right, like a lumbar puncture or if you want to add something like some type of anesthetic to the cord, like with an epidural, it's probably good to know where this is, because there's going to be some emptier spaces, some larger cavities below the L2, L3 disc space. So here, when you're seeing things like lumbar punctures or epidurals, right, it's good to know where these anatomical locations are, right, because you would want to be below that area. So again, it seems pretty mundane to learn these things at first because you're just memorizing random numbers. You're just memorizing random facts, but everything has a little bit of application to it. So a lot of times, if you are the person that's having to perform these procedures, you use anatomical landmarks to help you out too. You know, it's not like you can see through the body and do these things sometimes unless you got like an ultrasound guiding you, but you can actually, let's say, posterior thorax, lumbopelvic region. What you can actually do to guide you sometimes, see if I can find something that's got a little bit of everything on there, is you can actually use the tip of the iliac rim, and you stick your thumbs on that, you palpate that, and you move your thumbs medial. That'll put you in the right area, the right location. And so I know we can't really see the sacrum here. Let's move to an area that's got the bone present, or at least partially present. So here you can see L5, L4, L3, L2. So L2, L3 disc space would be right about there. That's where the cord terminates. So if I want to be safely below that, but still above the sacrum, because you obviously can't go through the sacrum, right? It's bone back here, solid bone. Then if I use the tips of the iliac crest and I bring my thumbs a little bit more medial, that'll put you in a nice safe space right here. So that'll end up being pretty close to what we're seeing right here. Isn't that nice? So you can use what's called anatomical landmarks. Dermatomes we already talked about. Dermatomes are areas of skin that are innervated or controlled by very specific, spinal nerves. And sometimes we'll say the word nerve root, because if the nerve root itself gets affected, then we will have change in the sensation of the dermatomes. Right? So for example, if I'm doing a test on a patient, a lot of times you can just use the sharp end of a reflex hammer. I always look for these in the class because I just expect them to be laying around somewhere. But this is what I was talking about in class one time. This is like the stylus end of a reflex hammer. It's pretty sharp. Right? So if you want to do a Babinski response on a patient, just take that thing and scrape it on the bottom of their bare foot. They're going to have a response for sure. Right? So you're not going to cut yourself, but it's sharp enough to cause pain, and that's what it's supposed to do. Right? So if you want to use like a dull end, you can use that if you want to. But, if I'm doing dermatomes, I can just lightly graze this across the skin, and I can be like, hey, can you feel this? And they're like, yep. And I'm like, how about this? Can you feel that? So you might test them bilaterally, because even if they're complaining about issues, let's say on the left side, I still want to test bilaterally, because if this area is kind of numb on them and this area is also kind of numb, what are things they're doing bilaterally that could cause that? Are they construction workers and they have a lot of callus buildup right there on both sides? So it might explain the numbness, but not why they're necessarily having pain. So you always want to do stuff bilaterally, right? Because there could be other explanations for why they're having unusual sensations or problems, right? That we can't just figure out by doing one little simple test. But again, if I'm testing dermatomes, I'm testing different areas of skin, and this is going to be one dermatome. That's a different dermatome. That's a different dermatome. So if they're complaining about numbness and tingling in the hand and they can't tell me exactly where it is, this is a good test to do, because what nerves control the hand, like motor and sensory? It's cervical nerves, right? Cervical spinal nerves. And the cervical spinal nerves, if I want to get down to it, also represent certain areas of the skin called dermatomes. So let's say they're complaining of lower neck pain and numbness and tingling of the hands. This would be a good test to do. So I might do this. I'll be like, can you feel this? And they're like, yep, I can feel that. And how about this? Does this feel the same as that? And they say yes. And then I might do this. I'll be like, how about this? Does this feel the same as this? And they're like, yes. And I'm like, okay, how about this? Does this feel the same as this? And they're like, do that again. And when they say do that again, that tells you something. That tells you that it's different than something that you've done before. So I say, how about this? Does this feel the same as that? And let's say this was the hand they were complaining of to begin with. And they're like, no. And I'm like, how about this? Does this feel the same as this? And they say, no. And I'm like, how about this? Does this feel the same as this? And they're like, yes. I'm like, so I'm basically gathering from them that they can feel this, they can feel that, this and this feel the same, this and this feel different, and this feel different. So that tells me that this is probably the area. So that would be my C8 dermatome. So I would probably want to look somewhere between like C7 and T1 in the neck on an X-ray if I already got an X-ray. So again, it helps you localize stuff. So, you know, and that could be a pretty common place to see something, you know, because some people can actually have, I think they're called pseudo ribs, sometimes up in the neck region, which could get in the way. Like some people have an extra rib sometimes up above where they're not supposed to. So that could explain why something's being impinged. Obviously, if I have a neck injury, that could cause the problem. Maybe a disc is getting involved. So we sometimes see some extra stuff down in the lower cervical region. But anywho, I'm just showing you how you can use this. But you can do pretty much anywhere in the body with dermatomes. So if somebody's complaining of sciatic-like pain, you know, and I want to narrow down which disc has been affected, you know, I can use dermatomes if I want to, right? But anywho. Another thing that is related to dermatomes is shingles. So shingles you've probably heard of before. This is where somebody at one time in their life had chicken pox. And over time, since chicken pox is a virus, usually those viruses, which kind of stay with you forever, they get sequestered somewhere. Like when you get into immunity, immunity is not all about kill, kill, kill. Remember, sometimes a good functioning immune system, rather than kill everything involved, might just sequester them or prevent them from spreading. And that's a lot of times what we do with viruses. Because when you're dealing with viruses, viruses are invading your cells. And the more viruses we kill, the more of our own cells we have to kill. That's why there's a lot of aching and pain usually associated with viral infections. It's usually the loss of our own cells. Maybe nerve cells are being destroyed, maybe muscle cells are being destroyed, and you can feel that. So it's very achy. So a lot of times when you have viral infections, they don't disappear entirely once the symptoms go away. They're still somewhere hidden in the body. And with shingles in particular, this is an old chickenpox virus that has now come back out again. It's kind of like broken out of prison. And with shingles, the old chickenpox virus was sequestered into your dorsal root ganglions, right? So that would essentially be along a portion of a spinal nerve. And when they are released, usually in times of stress, or we can no longer manage them because the immune system's working hard, fighting off something else, sometimes they can escape again. And with the shingles, it comes back as these painful, fluid-filled, what's called vesicles, right? But they tend to only follow a dermatome. So if I end up seeing a stripe of vesicles, right, that maybe follows some type of bandit pattern on one side of the body, but let's say not the other, that's a good indicator that that's probably shingles, because shingles will usually follow a dermatome. Right? Isn't that interesting? So again, it doesn't really matter which dermatome they're following. It really doesn't make any difference, but that helps you determine that it is shingles and not a different type of infection or erythema or coming from something else. So it'll usually be unilateral for the most part, and it usually forms like a stripe-like pattern. But anyway. So that's another use for dermatomes. And finally, we're going to talk about spinal cord cross-section and tracts. Again, we're going to go through these pretty quickly because I know we've done this already ad nauseum. And that's kind of the point of this class, is to make sure we're doing things ad nauseum. But real quick, let me talk about spinal cord cross-section, what all is involved. Let's talk about some of the important tracks and then what would happen if a patient had a problem with these tracks and maybe even where that comes from. And that'll knock it out for neuro. But I'm going to switch over to, sorry. Let me show you real quick. I was just showing people a picture of this. Sorry, forgot to share screen with you one more time. I'm only going to do that at least 13 to 17 more times this semester. But what I was looking at when I was talking about striping or banding pattern, I was showing a picture of shingles, and this is what it would look like. See how shingles kind of follows a stripe or band, unilateral, only on one side, so it's following a dermatome. So that's what shingles would look like. So in the PowerPoint, shingles was mentioned right here. And we just got done talking about dermatomes. And then I switched gears and we were going to talk about spinal cord cross-section. So I should show in this picture because this is what I'm about to draw. And I'll show you reflex arc real quick, because reflex arc just shows you how the body and the nervous system kind of work as a whole. It's a very simplified version of a communication between CNS and PNS, right? You know, we're going to pick up some type of sensation from the environment, internal or external. That's going to be traveling from the PNS toward the CNS. The CNS will then make a determination of what to do about this and send a signal back out to the body. So when you do spinal cord cross-section, something called a reflex arc is very good for just showing that type of communication. Sensory afferent coming in, CNS processing, some type of motor efferent coming out. It shows a very simplistic version of that. And then that leads up well to tracks, because the cord isn't really responsible for a lot of our evaluation, processing of information. The brain does most of that, but the cord can do some simple things called reflexes. But again, it'll make more sense as we start going over it. But this part I was going to show you on paper. So back to our page here, and let me use a pencil just in case. So when I draw spinal cord cross-section, I usually just draw something and always give the, well, that was actually pretty good. I always tell people mine are always asymmetrical. They're always lopsided. This one actually turned out kind of good, but it basically looks like a cartoon butt is what it looks like. So this is a spinal cord cross-section. And what we're seeing right now is the outer portion. I'm also going to draw this little portion on the inside. And for right now, we're just going to draw a very simplistic area of gray matter where we're only going to be seeing dorsal horn and ventral horn again. Okay. So again, gray matter versus white matter. Okay. What makes up gray matter? Cell bodies. Versus white matter equals axons that happen to be myelinated. Okay. So if I have some type of core demyelinating disease, right, where is it going to happen? In here, or out here, probably out here, right? So something called Devick's disease could do that. And Devick's disease presents very similar to MS, where symptoms kind of come and go. They're going to disappear, you know, large amounts of time, and then all of a sudden they kind of pop up, right? They're intermittent. They kind of come back. But again, the myelin that Devick's disease attacks should be intact for the most part, right? It's what's going to basically ensure that our amplitude is maintained, so we're not losing electricity out to the periphery of the body, because we have a lot of electrolytes that can carry electricity very well. So it's going to keep it along that neuron, that axon, if you will. And it's also going to speed up conduction, because myelin allows for what's called saltatory conduction, right? So we want our axons to be myelinated, and most axons are, right? About the only axons that aren't myelinated in the body are things called interneurons, because they're very short. I could show you an example of an interneuron on here if you want me to. But again, that's the big difference between gray matter and white matter. Is gray matter is mostly collections of cell bodies. So if I'm drawing say a multipolar neuron, right? Dendrites, 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 dendrites. Again, I'm not going to draw it that detailed every single time. Here's the axon. Here's the axon terminals where we're going to release neurotransmitters. This is the cell body, also called the soma. This part is unmyelinated. So if I just have a large accumulation of these, right, then because it's unmyelinated, it's going to appear darker. But if I have a large accumulation of these things, and all of them are kind of myelinated, that myelin together appears white. So this would be gray matter, this would be white matter. So anytime we're seeing gray matter and white matter in the brain or the cord, we can kind of make determinations. Well, if the gray matter is affected, we're not receiving information, we're not able to process information, we're not able to come up with ideas about how to do things like motor. But if white matter is affected, we're not able to transmit that information effectively, fast enough, or at all, right? So when I see gray matter somewhere in the CNS, that's where information is being processed. When I see white matter in the CNS, that's where information is traveling, right? So most of the white matter out here is tracks, and the information is traveling up and down the cord, right? So when we draw our spinal cord cross-section like that, very simplistic, and we want to keep it simplistic because you want to be able to recreate it very easily, right? Similar to our circle picture of the heart, right? Simple cross-section here. This is always going to be the dorsal aspect. This is always going to be the ventral aspect. So this is facing toward the back. This is facing toward the front, the belly. Okay. So ventral toward the belly, dorsal cord cross-section. You see this little horn-like projection sticking out back there on the dorsal side of the cord. We call that the dorsal horn. And then this little horn-like projection that's poking toward the ventral side of the cord, we call that the ventral horn. That's really about all you need for showing what's called a reflex arc or a reflex loop. So this is part of the cord. This part right here is cord. So cord's part of CNS, right? And a big overarching theme of the nervous system is to be able to respond to stimulus, right? So we can show an example of a response to stimulus just showing some of the basics of the cord, right? Because the cord is technically part of CNS, right? And it is connected to the periphery. Obviously, peripheral nerves, spinal nerves are coming from the cord. And for example, coming into this dorsal horn, you're going to have a lot of what we might call rootlets going on to make up a root back here. So I'm just going to draw a couple of these things. And they continue. All right. And the ventral horn right here is going to have some rootlets that go on to make up a root. And so where these little things are coming from, what I'm drawing here are axons. These are axons coming in. These are axons going out. Okay. Together, these end up making those rootlets that we saw in that real picture of the cadaver, right? But if I kind of wrap all these things up together, then this ends up being my dorsal root, this entire structure. This, if I wrap it up all together, ends up being my ventral root. And once the two join together to combine, now you have a spinal nerve, right? And remember, all spinal nerves are mixed in nature, okay? So now putting together all the information that we've learned in Anatomy 1, that we've learned in the past couple of weeks, right? How does the nervous system work? Well, it works by responding to stimulus. How do we pick up stimulus? Through things called receptors. Many of our receptors are located in places like our skin. So that's how we determine what's going on in our environment sometimes. Not all the environment, but a lot of it. We're picking up from the skin, right? So when I touch things, when I feel things, when there's pressure, itch, burn, that stuff has to make its way from the periphery to the CNS. So if I'm picking up from anywhere from like the neck down, it's usually going to be coming from spinal nerves rather than cranial nerves, right? So for example, if I'm picking up some type of sensation coming from this one particular finger, right? Eventually that's going to end up heading into the cord along the C6 nerve root. So this would go into C6 right here. This would go into the C6 area, right? Because it's coming from there, but it's actually going to ride along what's called median nerve. So median nerve is what's going to bring it in. And median nerve is a mixed nerve, just like all spinal nerves are. Some spinal nerves are very famous. You've heard of them, right? Not all of them have the, I guess the notoriety of median nerve. Median nerve is very well known because that's the one that's involved in carpal tunnel syndrome. But when you learned some of the nerve supply, like median nerve, ulnar nerve, radial nerve, right, axillary nerve, muscocutaneous nerve, those were major branches of a thing called brachial plexus. They all come out of the neck, right, and control things like the upper extremity and the shoulder. But you had some minor branches too, like lateral and medial pectoral nerve, the dorsal scapular nerve, the middle subscapular nerve, also known as thoracodorsal nerve. Those are all examples of spinal nerves, right? Those are all examples of spinal nerves. We just cover those a little bit more in detail because they control the upper extremity. And then in the lower extremity, we have very famous ones like sciatic nerve and femoral nerve and obturator nerve, which are coming from what's called the lumbosacral plexus. Some of the more important nerves coming from the spinal cord, but there's spinal nerves coming out from every little section, right? And when these spinal nerves, right, are out here, they are mixed in nature, right? All spinal nerves are mixed in nature. And some of the information that's traveling in those spinal nerves are heading inward or afferently, right? So when I have a signal coming into the cord in a sensory afferent fashion, it's always going to head in this direction, right? So the spinal nerve is out here and it's got lots of fibers inside of it. Like a nerve is just a collection of many, many thousands of neuronal axons. It's a bunch of fibers, right? But if I have sensory information coming in, that's always going to travel what's called afferently towards CNS to be processed. So it's going to head in toward this dorsal side of the cord right here. Right? Always. That's always going to be the case. So if I touch this finger right here, that information is going to travel along median nerve. I'm just telling you that, right? Because median nerve picks up touch from the first 3.5 digits, right? And you're probably confused at this moment. You're like, I thought you said that that was the C6 nerve root. It is. But when you get into brachial plexus and lumbosacral plexus, some of the famous nerves like median nerve and ulnar nerve are multiple nerve roots joined together. That's why they form a plexus, right? So if it's coming from this particular area along median nerve, it's going to enter into the C6 nerve root. If it's coming from this little area, even though it might still travel along median nerve, it's going to head into C7 nerve root. So again, I know that's weird, but that's how it works. So this sensory afferent information is going to travel up the arm, right, all the way to the neck. And right before it gets to the cord, it's going to take a little pit stop here in a place called the dorsal root ganglion, which is a collection of cell bodies. Because, that's not just one receptor right here. There's probably thousands of receptors where my finger is, and all those are traveling in, right? And there's thousands more receptors, and there's thousands and thousands of more receptors. So there's a lot of traffic going on in here. Lots of fibers coming in, for sure. Lots of fibers coming in, okay? But they're all heading to the same place when you're picking up things like touch, right? Any type of sensation, they're going to travel sensory, afferent. And which part of the cord are they going to go into? The dorsal horn. That's where they're going to enter first. Okay, so they're going to take a pit stop at the dorsal root ganglion. So a dorsal root ganglion, we've mentioned that before. That's a place where we find pseudo-unipolar neurons, right? But it's just a collection of cell bodies on the dorsal root, right? So this is my dorsal root ganglion. Okay. So let's say something was compressing my dorsal root ganglion. What am I going to lack in that person or patient or myself if it's me? The ability to pick up maybe touch, maybe pressure, sensation coming in from the body, right? Because what is housed in the dorsal root ganglion and the dorsal root in general? sensory afferent information. So it's picking up some type of sensation. So if this is pressurized or damaged, or this is pressurized or damaged, what am I going to lose? The ability to feel things. Right? And once we get into the dorsal root will be able to determine where it goes next. So it really just depends on what type of information it is. Like if it's touch, pressure, and proprioception, then we're just going to direct it up what's called the dorsal columns. If it's pain and temperature, we're going to direct it over to what's called the lateral spinothalamic tract. And those are going to be carried by white matter of the cord up to the brain to be processed. But some types of information that's coming in from the body to the cord can handle by itself. So if I were to touch something like, say, sharp or burning hot, right? Not only can I send that signal to the brain, but while the brain's waiting to receive that signal, an interneuron can actually send a signal between the dorsal horn to the ventral horn to a motor neuron, right? Because in the ventral horn, specifically, we have things called alpha motor neurons. In the ventral horn, we have motor neurons. So that's a motor neuron right there. That's a motor neuron. Here's an interneuron, very short, right? And then this motor neuron can send signals out, and maybe there's quite a few of them sending signals out, right? But this is going to be a motor efferent signal, right? Heading out to the periphery again, right? Of course, all this gets wrapped up in a sheath and forms a spinal nerve. But these motor efferent signals are heading out to an effector. And if it happens to be coming from the ventral horn, then that effector is going to be skeletal muscle. That's where that's heading. So if I were to touch something sharp or hot, sensory afferent comes into the cord says, hey, I'll tell the brain about this, but while he's about to receive that information, let me go ahead and do something about it because we need to move the body away because tissue damage is occurring. So let me go ahead and send a signal to the ventral horn. Ventral horn says, I got this. Let me just go ahead and contract this muscle here and pull it away. So I touch something sharp or hot, pull it away. That's a reflex. That's called a withdrawal reflex. But it's nice because as simplistic as that is, it shows how the entire nervous system works as a whole. You got some type of sensory afferent information picking up information about your environment. It's heading towards CNS in some way, shape, form, or fashion to be processed. So cord is part of CNS, just like brain is. And so if the cord can't do it, it'll send the signal up to the brain will do it. And so the cord can also act as a conduit between the body and the brain. It'll travel, information can travel up and down the cord as well, not just in and out, right? But once we've determined what to do about it with some part of the CNS, whether it's the cord or the brain, that information, if we're going to head somewhere between, the neck down to the foot, it's going to travel along spinal nerves, then the cord's going to send a signal back out again towards some type of effector, right? So now I can do something about it. So it shows everything being connected. But you could also think about, well, what would happen if anywhere along the sequence we got affected? Like what happens if I have an impingement of the dorsal root of a spinal nerve? You're going to lose the ability to pick up sensation. What happens if I have damage of the dorsal horn of the spinal nerve? You're going to lose the ability to pick up sensations. What happens if I have a problem with this part right here? Well, what's it carrying? Well, that's carrying touch, pressure, and proprioception. So I'd lose just touch, pressure, and proprioception, right? What happens if I have a lesion right here on the ventral horn of a spinal cord? Well, I'm going to lose the ability to control some type of muscle. Right? So maybe I'll have some type of muscle weakness, or maybe I would have some type of paralysis, right? What happens if the problem's here? Well, you're going to lose both sensory and motor, right? See how that works? So again, we have to know how everything's linked up because lesions can pop up anywhere. It can pop up before we even get to the CNS. It can pop up in the CNS itself. And depending on what part of the CNS it hits, the CNS has lots of different parts that are responsible for lots of different things, right? If we don't know what they do, then how can we determine if a deficit exists? So it's a nice little thing. And that's a lot of times what we end up using this spinal cord cross-section picture for. Okay? But we also said that cord doesn't control most of your responses. Hold on, let me share a screen with you real quick. So here's that little cross section that we just drew. Here's an example that we just used. Here's my sensory afferent information coming in. It says, ooh, that's pretty warm, right? Take a little pit stop here in the dorsal root ganglion. That cell of the body says, yep, that's important. Go ahead and talk to the dorsal horn about that. Dorsal horn says, oh, I know what to do about this. He says, let me go ahead and fix this. And in a minute, I'm going to send a signal along the lateral spinothalamic tract so we can tell the brain about it. But you've already moved before you felt the pain, right? Like when we touch something hot or sharp, you jerk back before you even notice it because the cord went ahead and took care of it for you and then told the brain about it, right? But not everything can be determined by the cord alone. A lot of things are determined by the brain. So how do we get to the brain from the cord? We use tracks. And vice versa. How do we get from the brain back down the cord? Tracks. So you end up with two different types of tracks. You have what's called ascending versus descending, right? The main ascending tracks that we learned were things like dorsal columns, which picked up touch, pressure, and proprioception, right? And technically, it's light touch, light pressure, and proprioception. And proprioception was, let me write this down for you, because it's good to hear it as many times as humanly possible. Proprioception equals sense of body position. I usually don't say that first. I'm just telling you overall what it is. But it's three things total, right? It picks up three things: muscle, stretch, tendon, tension, and then joint angle, we'll say awareness, joint position or joint angle awareness. So for example, if my eyes are closed and a physician manipulates one of my fingers, he might say, what finger did I move and what position is it facing in? My middle finger is pointing up, right? So if I can feel that, that's proprioception, the sense of where my body is in space without me having to look at it. So we use that a lot when we're walking, right? We don't like to look at our feet when we're walking. We like to walk and face ahead. So we need proprioception to be able to do that. So if I lose my sense of proprioception, what are you going to probably notice in a patient? They're probably going to look down at their feet all the time when they're walking because they can't feel the bottom of their feet, right? They can't feel when the heel's striking. They can't feel that angle of dorsiflexion. They can't feel the bottom of the feet, right? They can't feel when the foot's moving like this. So they are scared they're going to trip over that toe because they can't feel that angle anymore, right? So we have to give them proprioceptive training. So we see that a lot in dorsal columns injuries. When you have dorsal columns injuries, patient's gait gets affected. So that's one way we could tell, right? Is their gait gets affected. But with all ascending tracks, information does decussate at some point. Most information from tracks decussates in the brain. So in this case, it's going to decussate over around the medulla. So here's like information coming along dorsal columns here. Here's like the pons medulla right here. Crosses over, that's decussation, is to cross over. Crosses over. Lateral spinothalamic tract crosses over at the cord level that it entered. So, but it does decussate, it does cross over. All tracks will decussate at some point in time. But again, what does dorsal columns carry? Touch, pressure, and proprioception. So if I'm losing the ability to pick up touch, pressure, and proprioception, maybe it's a dorsal columns injury, right? Because let's say I can pick up pain and temperature, right? I feel that fine, but it's just touch, pressure, and proprioception I'm losing. Well, what part of the nervous system is solely responsible for touch, pressure, and proprioception? Dorsal columns. So if that's what I'm missing, right, but everything else is intact, let's look for a problem with dorsal columns. So what could possibly cause a problem with dorsal columns? Maybe diabetes, maybe pernicious anemia, right? Maybe neurosyphilis, right? So if I have a patient that can't feel things very well, right? They're starting to get some type of numbness. Maybe they have some type of gait manifestation where they're looking at their feet because they don't want to trip over their own toes and stuff like that. Then maybe they got something going on, right? So some tests that we can do to narrow down that it's dorsal columns and not something else, we can check for what's called asterognosis, agraphesthesia. Obviously the gait would be affected if they have balance problems, and patients usually present with this paresthesia. For some reason, they have numbness that shouldn't be there. That's the problem. So how would it, so let's say that they couldn't recognize an object by touch alone. Why is that dorsal columns, right? Well, if my eyes are closed and I place this pen in my hand, I showed you this the other day, how do I know what I'm feeling, you know, if I don't have touch, pressure, and proprioception? Pressure gives me kind of the weight, touch gives me the what it feels like, proprioception tells me the general size, right? Because of how bent my hand is versus how bent my hand is now, versus how bent my hand is now. It tells me how big something is or how small something is. Oh, there's my poodle. But you get the idea. So if a person can't judge an object by touch alone, we say they have astereognosis. Okay. So let's say we assume that they have a dorsal columns issue. Why is it there? Well, do they have high blood sugar and numbness and tingling and they can't judge an object by touch alone, or they can't feel the drawing of the skin? Or do they have a classic gait issue where they're looking at the feet, stomping the feet, and they have high blood sugar? Then it was probably a diabetes issue causing dorsal columns issues. Or do they have numbness and tingling that's kind of rare, and when we look at a CBC, they're anemic? Well, now we probably know which type of anemia they have. So now we'll do a Schilling test to see if it's a B12 deficiency. So it's just gathering information. That's all you're ever doing. But if dorsal columns is supposed to pick up touch, pressure, and proprioception, but for some reason I have a lesion on dorsal columns, guess what? I'm going to lose the ability to pick up touch, pressure, and proprioception. So that manifests in things like astereognosis, agraphesthesia, which means I can't feel drawing on the skin, balance problems. They'll be looking at the feet, stomping the feet because they can't feel when the bottom of the foot's hitting, right? So they're going for vibration sense, right? And they can't feel the angle of the ankle. So they don't know when the heel is down. They don't know when the toes are down. So they keep the feet flat and they stomp them, right? But this might be all they present it with. And now they walk away with a complete diagnosis. Look at that, right? And now we know how to fix it. So that's pretty cool. Well, you might not be able to fix everything, but still. Lateral spinothalamic tract picks up pain and temperature. So we would test for loss of pain and temperature. So simple test we can do is sharp dull test. So if I suspect that a patient has a lateral spinothalamic tract injury, I'm going to see if they can pick up the difference between sharp and dull. So again, I'll tell them to close their eyes and I'll touch them with something dull and I'll say, what does this feel like, sharp or dull? And they'll say dull. And then I'll touch them somewhere else and I'll say, how does this feel, sharp or dull? And they'll say dull. And I'll say, how does this feel, sharp or dull? And if they say dull, when I'm hitting them with something sharp, that's probably syringomyelia, right? So syringomyelia, most common reason somebody would have a lateral spinothalamic tract injury is a fluid-filled cyst that develops on the cord right in the middle, right where lateral spinothalamic tract decussates over. So here is lateral spinothalamic tract coming in. So this is, so nociception is the sensation of pain, temperature, right? That's coming in, goes into the dorsal horn, just like all sensation coming from the body does, right? Unless it's cranial nerves. But if it's coming into the spinal cord, it's going to go in dorsal horn. And when it's lateral spinothalamic tract, which is out here, it decussates over at the cord level. And a syringomyelia occurs right here, right in the middle, right where that central canal is, and it swells up. And so this can't get there, so they lose the ability of picking up pain and temperature. And most of the time, it occurs in what's called a shawl-like distribution of loss in pain and temperature, and glove-like paresthesia is present. So with syringomyelias, the distribution pattern, oops. It was like this. So they would lose the ability to pick up pain and temperature in those areas, and the hands, both sides, all around, front and back, is numb and tingly. So that's a nice differential from a peripheral nerve injury, because a peripheral nerve injury is not going to cover all the hands front and back. You know, if it's, let's say, median nerve, like let's say I had carpal tunnel syndrome, yeah, I might have paresthesia, numbness and tingling, but it would only come from the first 3.5 digits. Right? Here, 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 right? If I have radial nerve injury, it's going to come from the backside of that. If I have ulnar nerve injury, it's just going to come from that half of that finger and this finger, right? So if it's both hands, that's bilateral, right? Loss of pain and temperature, that can only be, lateral spinothalamic tract injury. So it distinguishes between whether it was a peripheral nerve problem or a tract problem, because touch and pressure was still fine. Proprioception was just fine. I just lost the ability to pick up pain and temperature, both hands, tops of the shoulders, easy peasy diagnosis, syringomegaly. Let's see, hold on, let me share again, just on a different page. And then anytime you get into cerebellar things, you're going to have the inability to properly coordinate muscle movements. So we just look for general ataxia. Same thing as if they had cerebellar damage. And I know we've gone forever without a break, but I assume most people are taking a break right now anyway. And then corticospinal tract, this is a descending tract. So these are motor tracts, and this is your main motor tract for controlling skeletal muscles. So if anything happens where this tract begins or anywhere along the way, then we're going to lose the ability to control skeletal muscles, and therefore we would call that some type of plegia or paresis, which usually means paralysis or partial paralysis, right? So if you have a corticospinal tract injury, I can't control skeletal muscles, so we're going to end up with some type of plegia or paresis, right? And again, when you're dealing with corticospinal tract, this actually starts in the brain, in the precentral gyrus. So the cerebral cortex, the outer portion of the brain, and then it goes down the spinal cord. So it's definitely descending, but it starts way up in the brain. So if I have a stroke in the brain of the precentral gyrus, like let's say on the left side, then I'm going to have right-sided paralysis or partial paralysis. All right. And so, again, this could be indicative of a stroke in the brain or somewhere in the tract itself. But if it's in the tract, depending on what level it's located, you could have ipsilateral paralysis or contralateral paralysis. Again, decussation comes into play here. We're not going to get that deep into the woods, obviously consult the neurologist. But you can at least know what's going on. If they can't control half of the body, like the upper extremity stuck in flexion and the lower extremity stuck in extension, then we either have some type of precentral gyrus issue on the opposite side of the brain, or we have some type of corticospinal tract injury, right? Something's putting pressure on the brain or the cord, or something has damaged the brain or the cord. That's what we know. Okay? But again, this can help narrow it down if you know what to look for. So we already looked at that gait, the hemiparetic or the hemiplegic gait. Again, you get stuck in flexion in the upper extremity, stuck in extension in the lower extremity. It doesn't always have to be both. It just depends on how big the damage was. Maybe it's just the upper arm is stuck in flexion. Maybe it's just the lower extremity stuck in extension, but that's why it's called hemi, because it's just on one side of the body or the other. Right? And then finally, upper versus lower motor neuron lesions. So I keep mentioning these all the time, but here's the slide that it's actually written down for you. And now it expands a little bit of where certain things can come from. Like if I have an upper motor neuron lesion, think brain or cord injury, right? So stroke would be the most common reason for an upper motor neuron lesion, but any type of trauma, swelling, blood clot, anything, can cause an upper motor neuron lesion if it's on the brain or the cord itself. MS, that's demyelinating disease, but it usually occurs in the cerebellum first and the cord first, upper cord first, right? And again, trauma. So pressure, bleeds, swelling, anything. So if the patient starts to get very rigid, right? If their reflexes are elevated and they have pathological reflexes present, and you can type these in Google if you want to, there's a lot of different pathological reflexes you can look for, then that's telling you that there's pressure on the brain or the cord, and that's usually good enough. Right? Because that will be enough information for you to make sure they go get a scan, maybe go get an MRI. If they are presenting with hyporeflexia, maybe muscles are weak or diminished, maybe they're starting to atrophy, then we're probably going to have some type of peripheral nerve injury. So that could just be simple, like a disc herniation, right? So long-term disc herniations and long-term sciatica, like piriformis syndrome, can actually cause lower motor neuron lesions. But it's pretty advanced, maybe thinking Guillain-Barré now. And then, of course, ALS is famous because it's got symptoms of both upper and lower motor neuron lesions. But finally, we finished neuro. So we'll take a quick break here, and I'm going to pause the recording. All right, so picking up where we left off, we had just gotten done talking about the neuro PowerPoint. I went ahead and opened up Neurosensory, but let me switch screens again real quick. All this time, we've been working on this neuro PowerPoint. So we started last week on Thursday. This Tuesday, we were getting through a good portion of CNS. So I think last Thursday we had gotten to slide 29. Tuesday we had worked through a good portion of the brain. It stopped, I think, at the reticular formation, which I can't remember which slide that was. Was that 62 or so? And then today, even though we're at Zoom meeting for 6-8, which was supposed to be all neurosensory, we had finished that. So that's what we've been doing today so far. And now that we've finally gotten done with neuro, we can look at neurosensory. And as I was opening this up, so you can see I've already opened mine. I think we can actually finish this today because a lot of the new information is right up at the beginning. So neurosensory, again, some of the basics that we want to know is, what are the special senses? Who's in charge of the special senses? Those are all cranial nerves, right? And once you know your cranial nerves, that knocks out a lot of learning neurosensory. So all the special senses and neurological exams with cranial nerves are pretty straightforward and easy. Like, how do you know if cranial nerve 1's working? Just ask them if they can smell or if their smell has changed, how do you know if cranial nerve 2 is working? Well, can they follow your finger? Can they see a Snellen and eye chart? Has the vision changed at all? Do they have peripheral vision? You can do cardinal fields of gaze. You can do lots and lots of tests to see if the cranial nerves 2, 3, 4, and 6 are all working. So that part's not very difficult, but at the very beginning of neurosensory, some of the things that I have added, it will get back into some of those categories again about being like somatic versus visceral. So we'll talk about that. And when you get into some of the visceral senses, like say the picking up of blood oxygen saturation or blood carbon dioxide saturation, those are very important, obviously clinically related things that we have to be familiar with. So let's go over those. We'll see how we feel once we get to the end. And if we end up doing more neurosensory next week, fine. If not, we might just go ahead and skip to autonomics and endocrine. We'll just kind of have to see how we feel. But I've already got my neurosensory open, so I'm just going to switch screens. And like I was mentioning to you just a second ago, special senses are pretty straightforward and self-explanatory, right? Special senses are going to be confined to the skull, usually quite unique in nature. We don't do it in other parts of the body. Like I don't smell from the bottom of my foot. I don't smell from the crease of my elbow. I only smell from my nose. So that's pretty unique versus say like touch. Touch is something I can do all over the place. I can feel with my elbow, I can feel with the tip of my nose, I can feel with the back of my head, my earlobes can feel things. I can feel stuff on the bottom of my foot. Sorry. So those are not special senses. Those are what we call general senses. Hold on. Sorry. So again, discerning from special senses versus general senses is pretty easy. But then when you get into general senses, things that can occur throughout the body, are they things that I'm consciously aware of, like touch, pressure, proprioception, itch, and burn? Or are they things that the body needs to be aware of to make homeostatic changes, but we aren't feeling in the forethought, the forethoughts of our mind? I don't feel, using that word loosely, pH. I don't feel partial pressure of carbon dioxide, right? Like I can feel touch. So those things are usually coming from internal organs or vessels. We call that viscerosensory. But it certainly makes sense that my body needs to know what's the pressure inside of my carotid artery right now. it makes sense that my body needs to know what's the, blood carbon dioxide saturation, right? But again, I'm not consciously aware of that. Okay. So again, that's somatosensory versus viscerosensory. When you get into the somatosensory, lots of different types of receptors pick those things up, like tactile receptors, baroreceptors, and sometimes some of the viscerosensory stuff might use things like baroreceptors. So one thing that we probably did in anatomy 1, and you can see it again here, is we categorized some of the different types of receptors into very generic categories first. Like if it's something called a mechanoceptor or mechanoreceptor, again, you can drop the RE if you want to. It's kind of like the act of picking up something versus the object that picks it up. It's really not much different, but mechanoception is the act of picking up some type of mechanical or physical change in the body. It's performed by a mechanoreceptor, right? So again, whether you have the RE there or not makes no difference. Chemoreceptors pick up some type of chemical change in the body, or chemoceptors, and then thermoreceptors or thermoceptors pick up temperature change in the body. So those are your big categories. And, when we get into somatic versus visceral, I mean, all three of these could apply to either one. Like I'm pretty aware of, the outside temperature right now. It feels pretty nice. I'm not really warm and I'm not really cold. So we're probably somewhere between 70 and 75, right? I don't really feel cool. I don't really feel hot. So I can kind of guesstimate what temperature we're at, but I don't know what my internal body core temperature is right now. So some of this is going to be somatic. Some of this is going to be visceral, right? Certain chemicals I can taste, right? Like if something's very acidic, I can taste sour. So some of that's somatic, right? But a lot of chemoreception is probably visceral, right? Pain, I can feel that. Certainly, I can feel pain, right? But again, with these categories, it's very generic. It's not saying whether it's somatic versus visceral. It's just saying there's different types of sensations I can pick up as a whole. So you'll have a mixed bag. Like touch, for example, tactile receptors pick up touch. Baroreceptors pick up pressure. And some of these things are going to be somatic. Some of these things are going to be visceral, right? So tactile is touch. Baro is pressure. So if I'm picking up pressure on the skin, that's somatosensory. If I'm picking up pressure inside my carotid artery, that's viscerosensory. See how it works? Again, if you are consciously aware, if I am aware, then it's somatic. If I'm not aware, then it's visceral. And visceral usually comes from internal organs. And blood vessels count as internal organs. Right. So, but all three can be picked up somatic or viscerally. Chemoreceptors, for example, pH, that's a chemical, right? I mean, that's caused by chemicals. So that's going to be some type of chemical acknowledgement, like that we have either too much or too little hydrogen ions, or too much or too little bicarbonate ions. So those are things we need to be aware of. The partial pressure of oxygen, the partial pressure of carbon dioxide, like blood oxygen and blood carbon dioxide saturations. We need to be aware of those things. But, nociception is also a type of chemical reception. So is smell. Smell is chemical because it comes from very particularly shaped molecules, right? Things have to have some type of aromatic ring structure to be able to smell it. So that's chemical related. But again, some of these will be somatic, some things will be visceral. And then thermoreceptors obviously pick up temperature. So those are the big categories that go into making up what we end up calling neurosensory. And all these things, again, we're going to have various different types of receptors that pick them up. You'll have various different types of nerves that might carry some of these things. Like, some of the cranial nerves are picking up sensation of touch from very particular parts of the face, or picking up the sensation of taste from different parts of the tongue. And you have peripheral nerves that are picking up touch and pressure from different parts of the body. And there's also going to be parts of the brain or the cord that are receiving these types of information. So if any of those parts get affected, of course, we're going to lose some of our ability to pick up sensation. And so you might have some type of numbness or just absence of stimulus, right? So again, it's pretty redundant in nature. but this is just focusing on the neuroanatomy and the neurophysiology from the sensory perspective. When we get into motor is actually even simpler than neurosensory. Motor can either be voluntary volitional, which is skeletal muscles, or controlled by autonomics and endocrine. So that's why we end up doing autonomics and endocrine next. It's more inclusive, in my opinion, than just doing some type of neuromotor course, right? Because neuromotor, I think, harps on voluntary and volitional too much, right? But anywho. So do you need to learn tactile receptors and corpuscles again? Is this going to be super clinically relevant? Probably not. But when you learn some of the tactile receptors and corpuscles, these again are things that we sometimes find in the skin. Like a lot of times when I'm picking up touch, skin's really good at that. Skin's one of our largest sensory organs, right? Because it's got lots of what's called tactile receptors. And you end up getting all these different types, like Meissner's corpuscles, Merkel disc, Pacini and Ruffini corpuscles, hair and organs. The reason I do want you to memorize these again is because they're easy test questions to throw on a standardized test. And one of the reasons they tend to pick on these things is because you see stuff like this. Most sensitive, lowest frequency. Anytime you find ESTs, like superlatives, whether it's the best or the lowest or the highest or the worst or the coolest or the awesomest or the densest, those are easy test questions. So it's best to learn these. The most famous, of course, of the tactile receptors are the Meissner's corpuscles and the Pacinian corpuscles. So Pacinian, just think deep pressure. It's located deeper in the dermal tissue, further down here. It's more encapsulated, so it takes more pressure to stimulate those things, versus Meissner's corpuscles, which are found closer to the surface of the skin, and they are much more for fine touch, discriminative type touch. And then the other word they might throw at you on a standardized test is when you find Meissner's corpuscles in the skin, yes, they are more superficial because they're more sensitive, but they're typically found in highest densities in what's called glabrous portions of the skin. So that's a word they like to throw at you just to see, do you know what that means? All right. So sometimes the things we learn, even though I try to keep it as clinically relevant as humanly possible, we just have to learn it because we know they're going to be a test question one day, right? So if I'm trying to think in my mind or memorize, what are some of the hairless portions of the skin? Lips, nips, and tips is what I always say, right? Like fingertips, lips, nipples. It's my dog. Those are hairless portions of the skin. So, but of course, that would include the palms of the hands as well. It's not just the fingertips, but the palms of the hands, the soles of the feet. Those are hairless. Those are called glabrous portions of the skin. I'm sorry. But hush, go sit down. You're a turd. Watch Stranger Things. And then the most sensitive of all the tactile receptors is the hair end organ. And again, for good reason. If a mosquito's too light to stimulate even a Meissner's corpuscle, it doesn't mean that we can't feel it, right? Because if it lands on a hair, then we're going to smack it, right? But hair end organ is the most sensitive of all the tactile receptors. That's an easy test question right there. When you get into proprioceptive receptors, that kind of goes along with some of the somatosensory stuff. Proprioceptive knowledge, again, is good for us to be able to go lay down. It's good for us to be able to determine where the body is in space without me having to look at it. But to some degree, it also ends up having to do with how tight the muscles are contracted and how taut the tendons are. Give me 1 second. So I'm picking up where I left off. I will share screen with you, and we had a little bit of a break there in between. because the dog went a little bit crazy, so he is back in and licking his private parts. So I think we're going to be okay for now. So we had just got done talking about different types of tactile receptors. Again, not difficult to learn. You're just memorizing names and basic functions of what they do. But we do want to kind of memorize those things just because they're easy test questions. So the more awareness you have, the better off you're going to be with standardized testing. One thing that we had just left off on is we had talked about proprioceptive receptors, or we didn't get into it just yet, but we talked about the general sense of proprioception, what it is and how it's used. So again, this is how we're able to tell where the body is in space without us necessarily having to look at it, which we use that all the time. You just don't think about it, right? Because we're intending to think about something else, right? So the whole goal is if I know where the body is in space, I don't have to look to see every single thing that I'm doing all the time. I can just kind of trust where it is and what it's doing. And when we pick up proprioception, it's a combination of things like muscle stretch, tendon tension, and then joint angle and position awareness. And they think a lot of where the joint angle and position is coming from, again, is coming from deep within the skin. So maybe pressure receptors within the skin that's kind of talking about stretch or compression. So that's where the joint angle or position awareness is. But muscle stretch itself, we pick up with muscle spindle fibers. And because muscles are more vulnerable when they're stretched out, one natural response that the body has is if a muscle spindle fiber gets stretched too much, it'll cause the muscle to contract to kind of protect itself. So when we start to overstimulate muscle spindle fibers, they tend to be what's called excitatory in nature, and they want to take the muscle back to its normal resting length or a contracted length. So muscle spindle fibers, again, pick up muscle stretch. They're excitatory in nature. So if we stretch it real quick, it'll naturally want to contract, right? And it's kind of a protective mechanism. But at the same time, we don't want to contract so much that we cause damage, right? So with Golgi tendon organs, these are located within the tendons themselves. And when they're overly stimulated, they tend to be what's called inhibitory in nature, because you don't want to overly contract a tendon because that'll just lead to a sprain. So these are, of course, naturally built into us. But the idea, though, is if you can stimulate Golgi tendon organs, then that'll cause the muscle to relax. So that's where trigger point therapy comes from. Like a lot of times when you have like these hard knots and lumps and bumps inside of a muscle, the assumption is the Golgi tendon organ has been too overwhelmed, too overworked, and it's hyperpolarized. So if I can go in there with like some digital pressure, like the tip of a thumb or something like that, or maybe some type of medical massage, then we can stimulate those Golgi tendon organs to start being active again and cause the muscle to relax. So sometimes a little bit of digital pressure in a tight muscle can cause it to relax. Let's see. Now we're kind of getting more clinically relevant, I think. When you get into some of the various different chemoreceptors in the body, of course, one type of chemoreceptor that we're pretty aware of is a nociceptor. And nociceptors are things that we use in the body to pick up pain, right? So nociceptors, again, is picking up some type of noxious stimulus, something that bothers you, and it would fall under the chemoreceptor category. But a lot of chemoreceptors are picking up chemical changes throughout the body, and it's looking for like increased levels of certain substances or decreased levels of certain substances. So like maybe the increased presence of hydrogen ions or bicarbonate ions, or the increased presence of blood glucose, or decreased presence of blood glucose, or the increased presence of certain hormones, right? Or the increased presence of calcium, perhaps, right? So we need these chemoreceptors as one of the main ways of maintaining homeostasis, because we have to have proper blood sugar levels, proper blood calcium levels, proper endocrine levels, proper fluid electrolyte balance, right? So even osmoreceptors, right, would fit under a chemoreceptor category because it's the presence of chemicals, right, in a solution. So lots of important stuff with chemoreceptors. Okay? One or several, I should say, parts of the body that you'll actually hear about being called chemoreceptors are things called central and peripheral chemoreceptors. And I know that's a very vague term, but when they say central and peripheral chemoreceptors, they're usually talking about ones that are found either in the brain or some of the major vessels for picking up blood oxygen and blood carbon dioxide saturation. And the central chemoreceptor we mentioned before in Anatomy 2, when we were talking about things like control mechanisms for the heart or control mechanisms for the lungs, right? Because when we're trying to control cardiac output, you know, there's a couple of different things that get involved, like heart rate, heart contractility, and that changes depending on what the metabolic need of the body is. So we usually say cardiac output equals metabolic demand. But how do we know what that metabolic demand usually is? Well, we usually rely on what's called a central chemoreceptor, picking up the concentration of CO2 and hydrogen ion concentrations, right? Because the more the body works, the more waste it produces through things like aerobic respiration of glucose. And CO2 and hydrogen ions are both produced during those reactions, right? Like, for example, in the Krebs cycle, CO2 gets produced. In electron transport chain, some of the hydrogen ions are released. And so again, the more the body works, the more the body's making energy, the more acidic it becomes, and increased presence of CO2 and hydrogen ions let me know that. So that's our main way for determining what cardiac output and respiratory rates and depths should be. So that's pretty freaking important right there, right? So when you hear about something called a central chemoreceptor, they're talking about a very specific part of the brain. Usually it connects with something called your nucleus attractus solitarius, and it'll pick up blood, carbon dioxide levels, and hydrogen ion levels. And that ends up being one of our main regulators for heart and respiratory function. But we also have what's called peripheral chemoreceptors that are dealing with the same concept. And these are a little bit more concerned with oxygen saturation or oxygen levels in the blood. So these tend to be found in more of the large vessels, right? So here they're showing a picture of an aortic arch right here where we find some peripheral chemoreceptors. And then here's the carotid sinus. So I'm assuming they mean that's brachiocephalic trunk. That's probably left common carotid. That's probably left subclavian right there. So as the common carotids come up, right, like let's pretend this is a heart, right? And let's say that this is the aortic arch. Brachiocephalic trunk is the one that comes off toward the right side. And then you have left common carotid and left subclavian. So if it's left common carotid, that means it hasn't split yet, right? Right common carotid is going to come off the brachiocephalic trunk. So as they go up the neck, eventually some of that vessel needs to go internally to supply the brain, while some of it's going to stay external to supply muscles of the head and neck, right? And similarly on this side. And there's usually an enlargement right there where that happens. And so this little area right here is called a carotid sinus, right? Right here and right here. So it's right at the bifurcation point of internal and external carotid arteries. So this is the left common carotid. Here's the right common carotid. This is the carotid sinus. And inside of that carotid sinus, you find lots of baroreceptors, which are determining how much pressure is in there, and some peripheral chemoreceptors. And similarly, in the aorta itself, we find some peripheral chemoreceptors, and they do pick up oxygen levels, right? Because we can't always just be dependent on CO2 levels, because sometimes a patient might experience something called hypercapnia, right? Where they're just constantly in a state of too high a CO2, and CO2 just basically stops being the normal stimulus that it normally is. So typically, as CO2 levels start to elevate in the body has this incentive to get it out quicker. So I need to get blood flowing faster. I need to get it to the lungs quicker. We need to breathe faster, maybe even deeper as we're expelling CO2. So as CO2 levels start to go up, it's going to increase both heart, cardiac, and respiratory function, right? But What if I'm constantly in a state of high CO2 levels, right? Sometimes our receptor just becomes numb. It's just like, oh gosh, I've been telling you and I've been telling you and you don't listen, forget it. I'm not going to tell you anymore, right? So now I'm going to be more reliant on some peripheral chemoreceptors. So now when we see low blood oxygen saturation, that's going to end up being our new stimulus, right? So when a patient is hypercapnic, right, you have to be difficult on, it's kind of difficult in how you treat them because you have to be careful not to oversaturate them with oxygen because that's the only thing that's driving their normal heart and respiratory function. So you can actually cause their lungs to shut down by giving them too much oxygen at once. Isn't that crazy? Because their central chemoreceptor is already broken. It's just tired. It's fatigued. And now they're relying on peripheral chemoreceptors, which is going to drive their heart and their lungs breathing. But if I just artificially give them a bunch of oxygen or quickly give them a bunch of oxygen, what's the driving force now? See what I mean? Isn't that crazy? So it's wild how things work and how treatment works. But again, we need to be aware of these things so we can reason out why things are happening the way they happen. So we're just gathering tools. That's all. We're just gathering tools so we can use them later. And again, my explanation might not mean anything to you now, but you'll be able to figure it out later if you have enough tools to work with. Okay. So what could possibly cause hypercapnia? Smoking a lot. You smoke 2-3 packs a day, I promise you, you're in a state of hypercapnia. So, but it goes over the bigger picture for you right here. Another thing that we have to monitor constantly, because again, from the simplest perspective, what does the body need to function? ATP. And how do I make ATP? Well, normally I'm burning sugar in the presence of oxygen, which is giving me that carbon dioxide and that hydrogen as byproducts. And the ATP was the product we were looking for, but we also produce waste to do that, right? So not only am I closely monitoring blood gas levels because of the concept of respiration, which is the exchanging of atmospheric gases with body cells, right? So they can do some type of internal chemistry. We also need something to release energy from in the presence of that oxygen. So that's what the oxygen is going to be used for. It's going to help us release the energy from some of our macromolecules like sugar, for example. So we also need to be very closely monitoring our blood sugar levels. And if the blood sugar levels are too high or too low, that's a problem. So what should they be, right? Something like this. So normally you'll memorize the number 100 milligrams per deciliter. That's pretty typical. So what's normal blood glucose? About 100 milligrams per deciliter. Right? But what happens if they're too high? What happens if they're too low? Both can be problems, right? So if they're too high, that could eventually lead to acidosis, right? It could cause nerve damage. It can cause damage to the eyes, right? So vessel damage, make the kidneys work harder. If it's too low, I can't produce enough energy. So I'm going to feel faint. I'm going to feel weak, fatigued, all that kind of good stuff. So obviously this is one of those things we have to monitor all the time. So who's involved with monitoring blood glucose levels other than the hypothalamus setting our normal goals of where we should be? Pancreas, believe it or not, can do that. So your pancreas is what's going to kind of be monitoring these levels. And if we end up having local changes like too much or too little blood glucose, then we can respond by releasing certain hormones, right? So how do we regulate blood glucose? Usually through the release of the hormones insulin and glucagon, right? Insulin and glucagon. So we'll talk about that, of course, like hyper and hypoglycemia, how we regulate that and what local changes are when we get into endocrine next week, right? But if my blood glucose levels are too high, what do we simply call that? That's called hyperglycemia. If that occurs over a long period of time, what do we usually call that? We usually call that diabetes, right? And so that's the main test for diabetes. If we're seeing that somebody has an unusually high blood glucose level, or maybe their blood glucose level doesn't drop fast enough, or maybe it doesn't drop low enough when they're not eating, right? Those could be good indicators that they're hyperglycemic or they're diabetic, right? So diabetes is going to come up again and again and again. Another indicator that you might end up using is something called A1C, right? And I know people have heard about that a lot more now than they used to. And it's a lot of times because of the drugs that we're producing, and it's tests that we can also use to test somebody for diabetes. And if somebody ends up having what's called a high A1C, that usually indicates that they've had high blood sugar over a long period of time, right? Which is indicating that changes are occurring. So high A1C kind of gives you a broader vision of high glucose over time, which is leading to these blood protein changes. But either way, again, why would somebody have chronic hyperglycemia? Diabetes. And some of the main signs and symptoms of diabetes is polydipsia and polyuria. So they're constantly thirsty, they're constantly peeing, which if you ever had me for a teacher, you know, I do that all the time. I'm always talking about, you know, how much coffee I drink and how much I have to go to the bathroom. So it's a problem that affects many of us, but there's other factors involved too. If you're drinking 2 fish bowls a day of coffee, you probably are also having polydipsia and polyuria, but you're probably not diabetic necessarily. So that's not the only things that we're going to be looking for. But over time, if you're chronically experiencing increased thirst, increased urination, the vision starts to go bad, maybe you start to notice some peripheral neuropathy or something like that, then yeah, that's a way better indicator. But again, these things will be tested if those things start to show up in the patient in a case history, right? If you got a patient complaining of numbness and tingling at the bottom of the feet, they got blurry vision and they're thirsty and peeing all the time, then absolutely the first thing you're going to do as a healthcare provider is test their blood sugar, right? And so one word that I might want to throw out at you, postprandial means after a meal, Okay? So just be familiar with that. But again, there's different types of diabetes. You could have too little insulin production, which is usually associated with an autoimmune disease that we call type 1 diabetes mellitus, or sometimes it's referred to as juvenile diabetes. And that was damage to your pancreas caused by an autoimmune attack, usually when you're very young, right? So that's why it's sometimes called juvenile diabetes, right? But probably more commonly nowadays, because of the American diet, you're seeing a lot more type 2 diabetes, which is usually, again, you could be producing too little insulin, but a lot of times the insulin might be normal, but your cells are just not responding the way they should. So we have what's called insulin resistance diabetes. So you can imagine if I'm just constantly stuffing my face with Jolly Ranchers, which I used to like to do that as well, over long periods of time, then the cells are just going to be like, oh my gosh, insulin again? What do you need now? So they start to wear out. So type 2 diabetes mellitus, usually we're going to associate that with obesity, right? Poor diet, lack of exercise, all that kind of good stuff, right? But you could also have it with pregnancy, right? You can become a temporary diabetic when you're pregnant. So pregnancy, again, is one of those catch-all differential diagnoses. So are they diabetic if they have the high fasting blood sugar, if they have high or chronically high hyperglycemia? Sure. Is it always going to be present? Well, if they got it when they're pregnant, it'll probably disappear once pregnancy's over, right? But still, it might be something you want to monitor, okay? So what is the treatment for diabetes? Well, you could become insulin dependent, you know, if you have type 1, so you'll just have to monitor blood glucose all the time. You might have to take proper amounts of insulin. Or maybe if you're type 2 diabetic, we need to treat some of the underlying cause, right? So increase exercise, increase, you know, your diet to include more fiber, less simple sugars, things like that. Have a more well-balanced diet, you know. And of course, education helps with that too. So this goes over some of the differences between type 1 and type 2. Let's see, what did I skip over here? So hypoglycemia. Hypoglycemia is one of those things that all of us have experienced before. You know, if you've ever just kind of like stood up real fast and all of a sudden you felt kind of lightheaded and you're thinking to yourself, all right, well, that's one of two things. I either got low blood sugar or low blood volume, and I don't seem to be bleeding anywhere. I don't have Addison's disease, so it's probably low blood sugar, right? So if I haven't eaten in a while, there you go. That's your reasoning. But if you happen to be an insulin dependent diabetic, and let's say you took your insulin and you forgot to eat, or you took too much insulin, that could be a problem too, right? So those are different reasons we could lead into hypoglycemia, which means too little blood sugar, or obviously too much, right? So usually hypoglycemia is when you have a resting blood sugar level less than 70 milligrams per deciliter. Pretty easy signs and symptoms: hungry, tired, maybe you feel dizzy and lightheaded when you stand up, right? Hangry, that's what we call it nowadays, right? Irritability, shakiness. So, but if it gets too low, yeah, you can die. So that's a big problem, big problem. So usually, how do we get to hypoglycemic? We're literally just too busy to eat, or most of the time it's improper treatment of diabetes. So again, you forgot to eat after you took your insulin, or you miscalculated your insulin dose. That's the most common reason somebody becomes hypoglycemic that shows up in a healthcare facility, right? People that haven't eaten all day aren't going to show up and saying, oh gosh, I feel dizzy and lightheaded and hangry, you know. But if it's extreme and they passed out, right, or they went into a seizure, that's when they show up. So most of the time that's coming from this. Could come from chronic alcoholism. Right? Kidney and liver disease also could be issues. But how do you go back? How do you treat hypoglycemia in the patient? Give them sugar. Isn't that nice? Right? So I thought this little sign was freaking hilarious. It says she wants the D%, you know? So they're actually talking about like D5, dextrose 5% is what they're usually talking about. And it's literally, you're giving them sugar. You're giving them sugar to their body. After that, maybe you want to give them some glucagon, right? Because glucagon's a natural way that we could increase free blood sugar. Because glucagon as a hormone, this is naturally, insulin and glucagon are naturally what's regulating blood glucose to begin with. But it's something that you can also give a patient if you need to. So if they are hypoglycemic and we want to increase blood sugar levels, well, let's try to naturally break down some stored sugar like glycogen, and glycogenolysis is a result of the presence of glucagon. Or maybe if I want to convert a non-sugar source into sugar, which we call gluconeogenesis, glucagon promotes that too, but it's slower. So what would you want to do first? The most immediate thing you can do, which is just give them sugar. Right. And so let's just do both while we're at it. Right. Just go ahead and take them into the complete opposite state if you have to. Right. Then we'll worry about that later. So that's kind of answering this question. So why do you do dextrose first rather than just glucagon? You know, we got to treat the most immediate symptom first, which is low blood sugar. Then we can start working on ways that we can naturally take it higher, or in a more natural, less direct way, take it higher. So blood sugar levels, how do we pick it up? How do we change it? We covered that. Osmoreceptors. Osmoreceptors are things that are there for fluid electrolyte balance, right? So when you're dealing with the body's osmolarity, we're talking about the number of dissolved particles per, say, liter of solution, stuff like that. And so number of dissolved particles rather than size, is kind of what points to osmolarity. So osmoreceptors are concerned about that. I'm supposed to say kinase, supposed to say kidneys. I'm sure you could have figured that out. But we have various different osmoreceptors in the hypothalamus and the kidneys. Your hypothalamus obviously is in charge of most of homeostasis. So it's setting osmoregulation. It's saying this is what's normal for my ICF. This is what's normal for my ECF. So let's make sure that we're abiding to these rules. So that way we don't have cells that are shrinking too much or cells that are swelling too much. So we talked about this before in an old fluids electrolytes chapter. So for example, let's say I'm osmoreceptors of the hypothalamus. So let's say these are hypothalamus osmoreceptors. And just like any cell, they have a cell membrane. Inside, you have a certain amount of dissolved substance. Outside, you have a certain amount of dissolved substance. And let's say this is either blood or interstitial fluid. Doesn't really matter which one it is. It could be both, right? So now we have ECF. This is all ECF. And this is ICF, right? So in order to maintain proper cell tonicity of cells, then we like to have relatively equal amounts of solute to fluid concentration outside of cells as we do inside of cells. We're trying to maintain isotonic environments. All right? We're trying to maintain isotonic environments. But what happens if I don't, say, drink enough? Like what happens if I'm dehydrated? If I'm dehydrated, a lot of this water tends to disappear, right? A lot of this water tends to disappear. And what that ends up doing is it causes the electrolytes that were dissolved in solution to appear more concentrated, right? And because we can't control where water goes inside or outside of a cell, because water can freely move through cell membranes, then that's going to cause these osmoreceptors to shrink or shrivel, right? Because we've created a hypertonic environment, right? So when I'm dehydrated, that creates hypertonic environments if I'm just losing water and not electrolytes at the same time. So if we're not drinking enough, and that's how we got there, then we create a hypertonic environment and our cell shrinks or shrivels. So while this cell is shriveled or crenated, that's what's going to make us thirsty, right? So pretty easy concept. And vice versa. Let's say these are hypothalamus osmoreceptors. And let's say that we have consumed a lot of sugar, salt, soy sauce, something like that, right? That's, let's say fluid volume's normal, but we've just consumed a lot of salt. That could also, create a hypertonic environment. And so the reason the cells will shrink this time is not necessarily because you weren't drinking, it's just I took in way too much solute. So that'll cause them to prenate again, and then you'll be thirsty. But this time it's not to replace water, but it's to literally dilute the solution again. So sometimes when you eat very salty foods and you're adding both sodium and chloride to solutions in much higher quantities, the body's naturally going to get thirsty for a long time because the kidneys are going to take a while to get rid of these solutes, right? It's going to take a while to get rid of those. So at that time, while we're waiting on the kidneys to remove the solute, we are thirsty because we're trying to dilute the solution, right? So pretty simple concept, really. All right. But that's osmoregulation. So hypothalamus is basically what's setting it. Kidneys are what's going to help us control it. But, kidneys, when you get into a fluid balance, are more for how much do we keep versus how much do we get rid of. They don't really have anything to do with intake. Hypothalamus is what generates thirst. Kidneys are what's going to ultimately remove proper amounts of fluids or electrolytes. And then when you get into thermoreceptors, again, that's just warm and cool. So warm receptors, of course, active between 25 and 45 Celsius, which is 75 to 115 degrees Fahrenheit. Cold receptors between 10 and 20 Celsius, which is 50 to 70 degrees Fahrenheit. And then once you get above 115 and below 70, usually nociceptors kick in. Usually it's painful. But in between 70 and 75, so between 70 and 75, you're really not feeling anything. Your thermoreceptors are just kind of dormant. It's like, okay, everything's fine. Everything's cool. Processing of information. If it's somatosensory information, we're usually going to be processed in the postcentral gyrus and the somatosensory association area. So areas 3, 1, 2, 5, and 7. Okay. So if I'm picking information up from the skin, joints, right, parietal lobe. So, however, if I'm picking up viscerosensory information, most of that's going to occur in brainstem. Okay. Brainstem. Here's that little nucleus I was talking about before, nucleus attractus solitarius. That's one that gets mentioned sometimes. It's like, hey, what's going on with the blood pressure? Hey, what's going on with the blood sugar? You know, not sugar, but blood carbon dioxide levels. Okay, well, here's what we're going to do about it. Okay. So again, heart and lung function are controlled through here too, brainstem. So we pick up information here, we control stuff here. Let's see. How do we get receptor information to the brain? Again, it could come from peripheral nerves if we're picking up touch, pressure, proprioception. And they'll be very specific for what areas of the body they're responsible for. If it's special senses, then it's going to be carried on cranial nerves, right? If it's viscerosensory, sometimes it's cranial nerves again, believe it or not. Like cranial nerve 9 and 10 actually pick up a lot of information from your internal organs. Right? Like sometimes when we're picking up distension in the aorta or distension in the carotid arteries, sometimes glossopharyngeal picks that up. Sometimes vagus can pick that up. And then our response usually gets carried along vagus, right? If we sometimes have a response in the parasympathetic nature. So we'll talk about that next week, obviously. Okay. So if I can't pick up information with peripheral nerves, right, what would happen? You know, maybe I would lose the sensation of touch or itch or burn, you know, possibly all of those, right? If it's an entire peripheral nerve, because it's not tract dependent, right? And then I would also maybe lose the ability to move stuff around, right? So when somebody gets carpal tunnel syndrome, that's a peripheral nerve issue where median nerve is affected. So not only do I lose, let me show you. So if I'm talking about median nerve distribution, it's the first 3.5 digits, palmar surface. This is what median nerve picks up. So I would lose the ability to pick up touch and pressure, proprioception, itch, burn, everything would start to get more and more numb. So you would start to feel distal paresthesia is what you would feel. As a patient, you would present with distal paresthesia. You would start to feel numbness and tingling acrally, and it starts to work its way back. But most of your sensations get lost there, not just one or the other. So it's not a tract issue, it's a peripheral nerve issue. So it's picking up sensory information before it ever gets to the cord, right? But you also might end up over long periods of time losing part of your what's called thenar eminence, right? Because if it's a peripheral nerve that's affected, like median nerve, not only am I going to lose some of my sensation, but I'm also going to lose the ability to control certain motor phenomena because peripheral nerves are all mixed, right? So check this out. So when you get median nerve entrapment, you can start to get atrophy in your thenar eminence. Okay? So that's muscle, right? And that muscle right there is usually pretty thick and big, right? But it disappears. So both. See you. Have a good one. So interesting stuff. Interesting stuff. But let's see. But let me see if I can go through and answer some of these things for you. I know there's a lot of question marks. Which peripheral nerve carries sensation from the palmar surface of the first 3.5 digits? That's median nerve. What tract carried fine touch, light pressure, and proprioception? Dorsal columns, right? So median nerve, dorsal columns, right? Tract carried pain and temperature, lateral spinothalamic. So let's say, for example, I'm trying to localize a lesion and I have numbness and tingling on the first 3.5 digits, or maybe just the thumb and the pointer finger, the index finger, second phalange. And I've lost all sensation. It's just pretty numb in general. Like it's not specific to touch, pressure, and proprioception. It's not specific to pain and temperature. I pretty much lost everything, and it's just pretty generally numb and paresthesia, right? Numbness and tingling. I'm also got weakness of my thumb, right? How would we diagnose that? Well, that's both sensory and motor. So again, I would think peripheral nerve, not tract. So what's eliminating some of the tracts here? Well, some of the information was lost from one tract, but information from another tract was also lost. Not only did they lose touch, pressure, and proprioception, they also lost pain and temperature. Everything was missing. So typically, when you have a tract injury, it tends to stay relatively close to that tract. It's not going to just skip over the entire cord, hit one tract and then hit another tract at the same time. That would be a total cord loss, right? It's not going to hit both dorsal columns and lateral spinothalamic tract simultaneously. That's an entire portion of the cord has been lost. Right. And they would work from different sides too. So you would basically have quadriplegia at that point. So again, if it's a peripheral nerve, I can distinguish that from a tract because it's going to span across multiple tracts that we're losing sensation from, plus motor deficits are also present. But if it's a tract, most tracts are either ascending or descending. They don't have mixed phenomenon. So it's either sensory loss or motor loss. So if it's corticospinal tract, perhaps it's just motor deficit, but sensory is all intact. If it's dorsal columns, it's a sensory deficit, but motor still intact, right? And if it's dorsal columns, I can still feel pain and temperature, but just light touch, light pressure, and proprioception are lost. See how it works? So again, when you're learning neuro, it's a lot about localizing lesions, right? And you can do that. The more tools you have, you can really get it narrowed down pretty far. But still, it takes a lot of thinking, I guess. Let's see. Lesions anywhere along the way could be mildly problematic to catastrophic, depending on the type of sensation gathered, where it's received. So what about carpal tunnel syndrome? Is that bad? It's a nuisance. Pretty easily fixed, though, if you get it early. So the weird thing about carpal tunnel syndrome, though, is it's the most misdiagnosed condition in the world. Most people that present with what they think is carpal tunnel syndrome are presenting with wrist pain, which really has very little to nothing to do with carpal tunnel syndrome. It's just misdiagnosed. Carpal tunnel syndrome almost always starts as distal paresthesia of the first 3.5 digits. So carpal tunnel syndrome is hardly ever wrist pain, right? Certainly it might be there, but that's usually not what would cause you to diagnose carpal tunnel syndrome, right? You might have wrist pain, but that doesn't mean you have carpal tunnel syndrome. But if you have wrist pain and numbness and tingling in the first 3.5 digits, there we go, right? And it usually starts distally and it works its way back, or acrally and works its way back. Now you're talking. Now you're talking carpal tunnel. But, how can I relieve carpal tunnel? Well, if it's pronator teres syndrome, then just stretch pronator teres. All right. If it's coming from your flexor retinaculum being too tight, then cut the flexor retinaculum. So it's not a hard fix. Let's see. Where would a syringomyelia rank? Maybe at first the loss of pain and temperature doesn't seem like such a bad idea. But the reason we're losing pain and temperature is because you have a fluid-filled cyst sitting on your cord. So when I say the word cyst on the cord, that sounds pretty bad, right? So eventually you're going to want to get that thing drained or looked at, or it's going to get bigger and worse and further, right? So yeah, that's at first not such a big deal because all I'm losing is pain and temperature. But when I get those cuts and burns on my hands all the time and you don't feel them anymore, and somebody asks you, why are your hands all cut up and burnt? You're like, I don't feel it. Then you need to go and look to see if they have a syringomyelia, because it can get much worse because that cyst can get bigger and eventually take over the cord, right? And then how about brainstem or hypothalamus tumor? Yeah, that's pretty much where it gets the worst right there, right? If I get tumors in the fore part of the brain, maybe I'll have cognitive disorders. If I get tumors in the cerebellum, which we sometimes do, MS creates lesions, and it's demyelinating lesions, but they also create scar tissue. So that does create tumors. Then you're going to lose coordination. So you'll be ataxic. But if I have a brainstem tumor or hypothalamus tumor, I can't control heart, lungs, or homeostasis in general, which would include heart and lungs too. So that's real bad. Right? So definitely certain parts of the brain and certain parts of the nervous system are going to rank higher importance than others. And then once you get into special senses, this is where, again, it gets super kind of straightforward and easy. Again, it's just kind of telling you what's the difference between general and special senses. Special senses are more unique and they're typically confined to the skull. This gets into basic definitions of receptor, sensation, perception, which is always nice because if you're doing true neuro, sensation is not a feeling. It's just raw data. Perception is how you feel about it, right? Like, ooh, that feels soft. And somebody else might say, ooh, that feels itchy. You know, sometimes our perceptions are different, even though we're feeling the same stuff, right? So the sensation, the raw data coming in is the same, but the perception might be slightly different for one person versus another. But usually they're pretty similar to each other. But if I can't get the information there, you can't perceive it. Therefore, you'll have the loss of the ability to feel, right, or perceive that information. And then projection, again, was that ability for us to send what we call a feeling to the area it was gathered, right? It's an illusion. It's not real, right? And so that explains sometimes why people get phantom limb issues. But if you know with the cranial nerves, which cranial nerve is responsible, which type of information am I picking up, what's the other name for it sometimes, like smell is also called olfaction, you're usually doing pretty good. And then knowing any diseases associated with the different special senses. You know, like if I lose the ability to smell, or if I lose the ability to taste, you know, that could be indicative of something, right? So we might call that ageusia, or some people call it ageusia, right? Loss of smell, anosmia, right? So that has come up more recently now, like you never probably would have heard these words before until COVID came along. And then the first variant of COVID, I think these were some of the main symptoms, right? Or the first strain of COVID was loss of taste, loss of smell. But you could also get that with certain types of viral infections that might cause damage to a cranial nerve, right? You could have a stroke, and the day before the stroke, you could smell and taste just fine. And the day after the stroke, you can't do either one. And a lot of times it's not because it affected both cranial nerves, but, you know, taste is very strongly associated with smell, right? So if I had a stroke and it happened to affect the very front part of the brain, then I might lose the ability to smell and I can't smell anymore, right? But anywho, so if you know the special sense, you know where it's occurring, you know the cranial nerve that's responsible for it, which type of information it is, then it's pretty easy to predict what would happen if I had damage to that cranial nerve or a lesion on that cranial nerve, right? So this just gets into the ear. So when you get into ear and eye anatomy, lots of parts, right? Lots of parts and pieces. So just strict vocabulary words. Different types of ear infections. Again, anything that's a superlative, always make sure you know that, because you're going to run into it more often than not. A lot of times, you know, what people end up doing in healthcare is they learn the very unusual things and I guess the more interesting things, but it's not always the most seen things. And people tend to not study the most seen things enough because they're like, oh yeah, I've heard of that before. I know what that is, but do you really, you know? So there's a saying sometimes in healthcare, if you hear hoof steps, don't think zebras, because here in America, we don't have zebras naturally. So if I hear hoof steps walking around outside, I'm going to think, oh, that must be a horse or maybe a deer or something like that. But I wouldn't think zebra. So if I have somebody that's got a bloody nose, am I going to think Ebola, right? Hantavirus, some type of hemorrhagic fever? Not here in America, you know. Are they bleeding out of their eyes and ears too? You know, maybe then. Or head trauma, or maybe they have some type of, you know, dry sinuses. I don't know. But again, I'm not going to think Ebola first thing off. So learn the most common things. If it says this is the most common form of this is the most common reason you get that, make sure you know that. Like, what's the most common reason for kidney failure, diabetes. So if you got somebody with chronic kidney disease, they probably are diabetic too, right? So those are useful. Or you can know what's going to come. Like if I have somebody with diabetes and they don't feel like taking care of it, just explain to them, well, you're going to have to get dialysis one day, right? Do you really want to do that 2 or 3 times a week? No. So take care of your diet better now. But learn the stuff that's most common. Learn the stuff that you're going to see more often than not, because we tend to forget about it because we're so overly inundated with it that we don't necessarily know about it as much as we should, because it's not cool and it's not interesting, it's not unique. But otitis externa, otitis media, otitis interna is basically saying that you know the different parts of the ear. And when you have an ear infection, like otic is ear, inflammation of itis, so otitis, inflammation of the ear. But we're going to have different symptoms if it's just affecting the tympanic membrane out versus the middle ear, which is here, versus the inner ear, which is here. So if I have otitis interna, I'm probably going to have sound and balance problems. If I have otitis externa, maybe just pain and sound issues. And if I have otitis, media, then I'm probably going to have pressure built up in the ear, right? So maybe hearing loss and pressure, because this fluid builds up in this little area. So again, it just kind of gets into the different parts of the ear, what's included. That's discussed back here. Right, and then what can happen to some of these parts. And then every once in a while, you'll also get, I'm sorry, I lost that other slide, there it is. And then every once in a while, you'll get some unique types of diseases, like Meniere's disease. That's a good one to learn, also known as endolymphatic hydrops. That one's frequently tested about it because it affects all parts of what we attribute as ear function. It doesn't affect all parts of the ear, but it affects everything that the ear's supposed to do. Like an ear is supposed to be able to pick up sound, right? And it's supposed to help you with balance and equilibrium, because this part is responsible for receiving all the sound information, the vibration energy that's coming in through here, hitting that tympanic membrane. Tympanic membrane then transitions that vibration to these ossicles. And then the ossicles will hit this cochlea and cause fluid to start to move around. And inside the cochlea, you got these hair cells that'll wave. And that waving of the hair cells at different vibrations and frequencies is what gives us the sensation of sound, right? But up here, we're not concerned about sound. We're concerned about balance and equilibrium. So if I end up having Meniere's disease, all that gets messed up, all that. So I start hearing things that aren't there, right? Which we sometimes call tinnitus. And tinnitus doesn't always have to be a high-pitched ringing of the ear. It can sometimes be a low-pitched swooshing, right? So think about listening inside of a seashell. Sometimes tinnitus sounds like that, right? But it's just hearing things that aren't there. And then you're going to have gradual hearing loss and vertigo, which is the sensation of the room spinning. So if you have all three, tinnitus, vertigo, and gradual hearing loss, then think Meniere's disease or endolymphatic hydrops, and it comes and goes. Right? But if I just have gradual hearing loss and tinnitus, that's not Meniere's disease. Do you have the vertigo? No, then it's not Meniere's, right? If it's Meniere's, it's got all three. It's kind of like a syndrome. But sometimes when you say the word syndrome, that means you have to have like a certain minimal number of signs and symptoms, and those signs and symptoms always have to be present. So I could have gradual hearing loss just because I'm old, right? Or I went to too many concerts, or I listened to my earbuds too loud, right? And I can have tinnitus because I'm taking blood thinners or aspirin, right? So you can have both of those together, and it's not any disease necessarily. I mean, it kind of is, but not really. But you had the vertigo in, then you probably got Meniere's, right? But I could have vertigo and not necessarily have Meniere's disease, right? Because I could have vertigo with any type of inner ear infection. So if I had a middle ear infection that spread to the inner ear and that's infected and swollen, then yeah, you might have some little bit of hearing loss, but you would probably get a sensation of the room spinning or a feeling of imbalance, right? So it wouldn't be good to drive if you had vertigo, right? Let's see. So this gets into different types of hearing loss, like conductive hearing loss versus sensory neural. right? Like, is the sound getting there? Is the pathway open? Is the pathway clear? Is everything vibrating the way it's supposed to vibrate, right? Is everything connected together from here to there the way it's supposed to be? Or is the problem a little bit further in? Is the nerve dying, right? Is there a stroke somewhere on the brain receiving that type of information? And again, there's a most common right here. What's the most common type of permanent hearing loss? Sensory neurohearing. And let me see. Make sure you know the difference between what rods and cones do. So made it a little bit easier for you. Rods pick up outline, good at night vision. So black, white, shades of gray. Cones add color and clarity. And so if I can refract light appropriately in the eye, it should hit what's called our fovea centralis, which is very rich in cones. So we're more diurnal creatures. We see better in the daylight. Color, we have good color vision. If you ever asked what type of vision humans have, we have what's called stereoscopic vision. And we have good depth perception. I already mentioned this when I talked about the occiput or the occipital lobe the other day. I was talking about hemianopsias, right? And the optic chiasma is an anatomical structure where information from the optic nerves meet and cross over. So some information coming from the eyes always stay ipsilateral. Some information coming from the eye crosses over at the optic chiasma and crosses to the opposite side, right? So optic chiasma, or the chiasm, sometimes they'll drop that A right there, is usually found right where the pituitary gland's at, right? So if I end up having a pituitary tumor, that could put pressure on my optic chiasma. And again, neurological structures don't like pressure. They stop working when they're under too much pressure. So again, you could end up getting hemianopsia with a pituitary tumor. Right? So what would I expect if I had a pituitary tumor? Probably some glandular issues, but you tie in glandular issues to hemianopsia, you got a pretty good diagnosis going on right there, right? So putting pieces together. And then some of the other eye issues that you've seen before. So terms you should be familiar with: anascoria, meiosis, mydriasis. These would be good things to write in notes if you note them in a patient, right? Like again, if somebody has Horner syndrome that we'll talk about next week, they'll have meiosis, ptosis, and anhidrosis, right? So hopefully I'll mention that again next week when we talk about autonomics and endocrine. And here's some fun stuff to do. Looking at some different things. So stare at these for a little while. The cool thing about this, I mean, these just kind of move because the eyes, they have blind spots that we kind of fill in the gaps and stuff like that, so we can get these different visual phenomenon that appear to be moving, or the spots tend to fill in with color, disappear with color. But here, look at this. This and this are the same color. This and this are the same color. This, and this are the same color. Isn't that wild? I mean, obviously A and C look the same, but A, B, and C are the exact same color. Isn't that cool? But that and that are the same color, and that and that are the same color. So your eyes aren't giving you a perfect image of what's in the world. They're guessing a little bit, but it's fascinating how they work. So anywho, that will wrap us up for our neurosensory. So today was a little bit unusual. Today was our Zoom meeting for 6/8. I was going to finish up neuro, start working on neurosensory. I went ahead and got done with that, so we don't have to carry that over till next week now. I went way past time, and most of the people checked out earlier because Oscar, turd sandwich over there that's fast asleep on the ottoman now, was being noisy. So I went ahead and let people go about an hour ago, and I'm just finishing this up at home all by myself. You know, Frank stuck around for a little while, but even he had to leave. He had another class. So I'm just recording this, and I'm going to post it in just a little bit. Obviously, that's what you're going to be watching. But that means that when we get into our Zoom meeting for 6:13, we're just going to go ahead and start and pick up here. So I'll label this appropriately, and I'll post it here in just a little bit. But I will see you next week. If you have any questions between now and next week, email me at any time. I'll answer those for you. And yeah, so have a good rest of the week and weekend. I'm going to go ahead and stop sharing. I'm going to go ahead and stop the recording.